Greetings to all aspiring healthcare professionals and educators joining us from across the globe. I am Professor Dr. Anas Rashid, and it is my distinct pleasure to welcome you to our comprehensive and interdisciplinary journey through pharmacology and therapeutics. With a European PhD in vascular medicine, physiology, and pharmacology, complemented by extensive postdoctoral training in experimental medicine, surgery, and translational medicine, I bring to this series a deep rooted passion for advancing knowledge and fostering collaborative learning experiences. Welcome to the Integrated Pharmacology Therapeutic Lecture Series. The lectures are organized as follows. Each lecture in this series will be meticulously crafted to provide you with a holistic understanding of pharmacology and therapeutics, empowering you to excel in your respective fields and make meaningful contributions to the advancement of healthcare. Lecture 2, Drugs Acting on Autonomic Nervous System and 60 Questions with Answers. Nervous system is divided into two parts, central nervous system, peripheral nervous system. Central nervous system is further subdivided into brain and spinal cord. Brain receives and processes sensory information, initiates responses, stores memories, generates thoughts and emotions. Spinal cord conducts signals to and from the brain, controls different activities. Peripheral nervous system, motor neurons and sensory neurons. Motor neurons, CNS to muscle and glands, and sensory neurons, sensory organs to central nervous system. Motor neurons are further subdivided into somatic nervous system and autonomic nervous system. Somatic nervous system controls voluntary movements. Autonomic nervous system controls involuntary responses, which include sympathetic deviant and parasympathetic deviant. Sympathetic deviant include fight or flight. Parasympathetic deviant include rest or digest. Further, autonomic nervous system regulates unconscious body functions to maintain homeostasis. Sympathetic, structure and function, structured nerve fibers, preganglionic that rise from thoracic and lumbar regions of spinal cord, join a prevertebral ganglion, then from here nerve fibers exist postganglionic and connect to the vertical organs. Functions include dilation of pupils of the eyes and bronchioles of lungs, increases heart rate, blood glucose concentration, blood to skeletal muscles, slows peristaltic action, decreases glandular secretions, blood to digestive organs, relaxes muscles of bladder and urinary bladder. Parasympathetic structures nerve fibers, preganglionic that arise from brainstem and sacral region of the spinal cord to join the nerve fibers, postganglionic in the muscles and glands. Functions constrict pupils of the eyes and bronchioles of lungs, decreases heart rate, blood glucose concentration, blood to skeletal muscles, increases peristaltic action, glandular secretions, blood to digestive organs, contracts muscles of gallbladder and urinary bladder. Major autonomic receptors are cholineoceptors, muscarinic M1, CNS neurons, sympathetic postganglionic neurons, some presynaptic sites. Results include formation of IP3 and DAG, increased intracellular calcium, muscarinic M2 in myocardium, smooth muscle, some presynaptic sites, CNS neurons, opening of potassium channels, inhibition of adenyl cyclase, muscarinic M3, exocrine gland, vessels, smooth muscle and endothelium, CNS neurons, like M1 receptor ligand binding, muscarinic M4, CNS neurons, possibly vagal nerve endings, like M2 receptor ligand binding, muscarinic M5, vascular endothelium, spatially cerebral vessels, CNS neurons, like M1 receptor ligand binding, necronic NN, postganglionic neurons, some presynaptic cholinergic terminals, receptors typically contain 2 alpha-3 and 1 beta-4 type subunits in addition to gamma and theta subunits, opening of sodium potassium channels, depolarization, neutronic NM, skeletal muscle, neuromuscular, and plates. Receptors typically contain 2 alpha-1 and beta-1 type subunits in addition to gamma and delta subunits. Opening of sodium potassium channels, depolarization. Adrenoceptors, alpha-1, postsynaptic effector cells, especially smooth muscle, formation of IP3 and DAG, increase intracellular calcium, alpha-2, presynaptic adrenergic nerve terminals, platelets, lipocytes, smooth muscle, inhibition of adenyl cyclase, decrease CMP, beta-1, postsynaptic effector cells, especially heart, lipocytes, brain, presynaptic adrenergic and cholinergic nerve terminals, juxtaglomeralar separators of renal tubules, ciliary body epithelium, Stimulation of adenine cyclase increase CAMP. Beta 2, post-synaptic effector cells, especially smooth muscle cell and cardiac muscle. Stimulation of adenine cyclase increase CAMP, activates cardiac GI under some conditions. Beta 3, post-synaptic effector cells, especially leukocytes, heart. Stimulation of adenyl cyclase and increase CMP. Dopamine receptors, D1, DA1, D5, brain effector tissues, especially smooth muscle cell of the renal vascular bed. Stimulation of adenine cyclase increases CMP. D2, DA2, brain factor tissue, especially smooth muscle, presynaptic nerve terminals. Inhibition of adenine cyclase, increased potassium conductance. D3, brain, inhibition of adenine cyclase. D4, brain, cardiovascular system, inhibition of adenine cyclase. So, cardiac beta 3 receptor function is poorly understood, but activation does not appear to result in stimulation of rate or force. Let's start with cholinergic agonist. Cholinergic drugs act on receptors activated by acetylcholine. Adrenergic drugs act on receptors stimulated by norepinephrine or epinephrine. Cholinergic and adrenergic drugs act by either stimulating or blocking receptors of autonomic nervous system. Figure summarizes cholinergic agonist. Preganglionic fiber terminating in adrenal medulla, autonomic ganglia, both parasympathetic and sympathetic. And postganglionic fibers of parasympathetic deviant use acetylcholine as a neurotransmitter. Postganglionic sympathetic deviant of sweat glands also uses acetylcholine. Cholinergic neurons innervate muscles of somatic system and play an important role in central nervous system. So these are the examples of drugs: direct acting, indirect acting, reversible, indirect acting, irreversible, reactivation of acetylcholine esterase. Cholinergic agonist neurotransmission involves 6 sequential steps. Step 1 is synthesis of acetylcholine. Choline is transported from the extracellular fluid to the cytoplasm and of the cholinergic neurons by an energy-dependent carrier system that co-transports sodium and can be inhibited by a drug. Hemicholine. Choline has a quaternary nitrogen and carries a permanent positive charge and thus cannot diffuse through the membrane. The uptake of choline is the rate-limiting step in acetylcholine synthesis. Choline acetyl transferase catalyzes the reaction of choline with acetyl coenzyme A to form acetylcholine and ester in the cytosol. Step 2, storage of acetylcholine in vesicles. Acetylcholine is packaged and stored into presynaptic vesicles by an active transport process. The mature vesicle contains not only acetylcholine but also adenosine triphosphate and proteoglycan. Co-transmission from autonomic neuron is the rule rather than the exception. This means that most synaptic vesicles contain the primary neurotransmitter, here acetylcholine, as well as co-transmitter, here ATP. That increases or decreases the effect of the primary neurotransmitter. Step 3 is release of acetylcholine. When an action potential propagated by voltage sensitive sodium channels arrives at a nerve ending, voltage sensitive calcium channels on the presynaptic membrane opens, causes an increase in the concentration of intercellular calcium. Elevated calcium levels promote the fusion of synaptic vesicles with the cell membrane and the release of contents into the synaptic space. This release can be blocked by botulinum toxin. In contrast, the toxin in black widow spider venom causes all the acetylcholine stored in synaptic vesicles to empty into the synaptic gap. Step 4 is binding to the receptor. Acetylcholine released from the synaptic vesicle diffuses across the synaptic space and binds to postsynaptic receptors on the target cell, to presynaptic receptors on the membrane of the neuron that release acetylcholine, or to other targeted presynaptic receptors. The postsynaptic cholinergic receptors on the surface of affected organs are divided into 2 classes, muscarinic and nicotinic. Binding to a receptor leads to a biological response within the cell, such as the initiation of a nerve impulse in a postganglionic fiber or activation of specific enzyme in effector cells as mediated by cyclic messenger molecules. Step 4 and then step 5 is the degradation of acetylcholine. The signal at the post-junction effector site is rapidly transmitted because acetylcholine esterase cleaves acetylcholine to choline and acetate in the synaptic cleft. Step 6, the last step, is the recycling of choline. Choline may be recaptured by a sodium-coupled high-affinity uptake system that transports the molecules back into the neuron. There, it is available to be acylated into acetylcholine. So cholinostimulants include, and their action are nerve, heart and smooth muscle, glands, and endothelium. Muscarinic, drug-acting drugs, alkaloids, polyesters, indirect acting drugs, reversible and irreversible. So nicotinic include neuromuscular and plate, skeletal muscle, autonomic ganglionic cells. So cholinergic receptors or cholineceptors, two families of cholineceptors designated muscarinic and nicotinic receptors can be distinguished from each other on the basis of their different affinities for agents that mimic action of acetylcholine, cholinergic agents. A. Muscarinic receptors. Muscarinic receptors belong to class of G protein-coupled receptors known as metabotropic receptors. These receptors, in addition to binding acetylcholine, also recognize muscarine and alkaloid in certain poisonous mushrooms. By contrast, muscarinic receptors show only a weak affinity for nicotine and alkaloid found in tobacco and other plants, as shown in figure. There are 5 subclasses of muscarinic receptors. However, only M1, M2, M3 receptors have been functionally characterized. Muscarinic receptors are found on autonomic effector organs such as heart, smooth muscle, brain, and exocrine glands. All 5 subtypes are found on neurons. M1 receptors are found on gastric parietal cells, M2 receptors on cardiac cells and smooth muscle, and M3 receptors on bladder, exocrine gland, and smooth muscle. Drugs with muscarinic action preferentially stimulate muscarinic receptors on these tissues, but at high concentration, they may show some activity at nicotinic receptors. So what are the mechanisms of acetylcholine signal transduction? Number of different molecular mechanisms transmit signal as generated by acetylcholine occupation of receptors. For example, when M1 or M3 receptors are activated, receptor undergoes conformational change and interacts with G protein that activates phospholipase C. This ultimately leads to production of secondary messengers inositol 1,4,5 triphosphate and diacylglycerol. Inositol 1,4,5 triphosphate causes an increase in intercellular calcium, and then calcium can then interact to stimulate or inhibit enzymes or to cause hyperpolarization, secretion, or contraction. Diacylglycerol activates protein kinase C, an enzyme that phosphorylates numerous proteins within cell. In contrast, activation of M2 subtype on cardiac muscle stimulates G protein that inhibit adenyl cyclase and increases potassium conductance. Heart responds with decrease in rate and force of contraction. Muscarinic agonist. Pilocarpine is non-selective muscarinic agonist used to treat xerostomia and glaucoma. Attempts are currently underway to develop muscarinic agents that are directed against specific receptor subtypes. This figure shows the affinity, so low to high affinity. So muscarinic receptors has high affinity, then acetylcholine, and then nicotine. Nicotinic receptors, in addition to binding acetylcholine, also recognize nicotine but show only weak affinity for muscarine, as shown in this figure. It is composed of 5 subunits and its function as ligand-gated ion channel inotropic receptors. Binding of 2 acetylcholine molecules elicits a conformational change that allows entry of sodium ions, resulting in depolarization of effector cell. Nicotine at low concentration stimulates receptor, whereas nicotine at high concentration blocks receptor. Nicotinic receptors are located in the central nervous system, adrenal medulla, autonomic ganglia, and neuromuscular junction in skeletal muscles. Those at neuromuscular junction are sometimes designated an M and others an N. Nicotinic receptors of autonomic ganglia differ from those of neuromuscular junction. For example, ganglionic receptors are selectively blocked by mica, mile, amine, whereas neuromuscular junction receptors are specifically blocked by atracurium. This table shows the properties of acetylcholine receptors, muscarinic, M1, neural, autonomic ganglia, presynaptic nerve terminal, and CNS. Increase IP3. Effects are modulation of neurotransmission, M2 cardiac tissue, sinoatrial and atrioventral nodes. Increase potassium influx or decrease CAM, slowing of heart rate and conduction. M3 granular, smooth muscle and glands, muscular smooth muscle. Increase IP3, increase CGMP as a result of nitric oxide stimulation. Effects contraction of smooth muscles and stimulation of granular secretions, and also vasodilation. Nicotinic, muscle type, neuromuscular junctions, increased sodium influx, muscle contraction. Ganglionic type are on autonomic ganglia, increased sodium influx, neuronal excitation. CNS type, CNS, increased sodium influx, neuronal excitation. So here, CMP is cyclic adenosine monophosphate, CGMP is cyclic guanosine monophosphate, CNS is central nervous system, IP3 is inositol triphosphate. And we can see the affinity. So nicotine has high affinity as compared to muscarine on nicotinic receptors. Direct acting cholinergic agonist. Cholinergic agonists mimic effects of acetylcholine by binding directly to choline receptors, muscarinic or nicotinic. These agents broadly classified into two groups. One, choline esters, which include endogenous acetylcholine and synthetic esters of choline, such as carbachol and butanochol. Naturally occurring alkaloids such as nicotine and pilocarpine. All drugs have a long duration of action than acetylcholine. More therapeutically useful drugs, pilocarpine and butanochol, preferentially bind to muscarinic receptors and are sometimes referred to as muscarinic agents. However, as group drug-acting agonists show little specificity in their actions, which limits clinical usefulness. So, acetylcholine is quaternary ammonium compound that cannot penetrate membranes, although it is neurotransmitter of parasympathetic and somatic nerves as well as autonomic ganglia. It lacks therapeutic importance because of its multiplicity of actions, leading to diffuse effects and its rapid inactivation by cholinesterases. Acetylcholine has both muscarinic and nicotinic activity. Its actions are decrease in heart rate and cardiac output. So, actions of acetylcholine on heart mimics effects of vagal stimulation. For example, if injected intravenously, acetylcholine produces a brief decrease in cardiac rate, that is bradycardia, and cardiac output, mainly because of reduction in rate of firing at sinoatrial node. Normal vagal activity regulates heart by release of acetylcholine at sinoatrial node. Decrease in blood pressure. Injection of acetylcholine causes vasodilation and slowing of blood pressure by indirect mechanism of action. Acetylcholine activates M3 receptors found on endothelial cells lining smooth muscle of blood vessels. This results in production of nitric oxide from arginine. Nitric oxide then diffuses to smooth muscle cells to stimulate protein kinase G production, leading to hyperpolarization and smooth muscle relaxation via phosphodiesterase 3 inhibition. In absence of administered cholinergic agents, vascular cholinergic receptors have no known function because acetylcholine is never released into blood in significant quantities. Atropine blocks these muscarinic receptors and prevents acetylcholine from producing vasodilation. So this is a diagram showing esters of carbamic acid resist hydrolysis by acetylcholine esterase, carbachol derivative of acetylcholine, pilocarpine is a natural product, and which is known as acetylcholine bond cleaved by acetylcholine esterases. Other actions. In gastrointestinal tract, acetylcholine increases salivary secretion, increases gastric acid secretion, and stimulates intestinal secretion and motility. It also enhances bronchiolar secretion and causes bronchoconstriction. Methacholine, direct-acting cholinergic agonist, is used to assist in diagnosis of asthma due to its bronchoconstriction properties. In genitourinary tract, acetylcholine increases detrusor muscle tone, causing urination in eye. Acetylcholine is involved in stimulation of ciliary muscle contraction for in-ear vision and constriction of pupillary sphincter muscle, causing meiosis, marked pupil constriction. Acetylcholine 1% solution is instilled into anterior eye chamber to produce meiosis during ophthalmic surgery. Butanochol is unsubstituted carbamyl ester, subsexually related to acetylcholine. It is not hydrolyzed by acetylcholine esterase due to acidification of carbamic acid. Although it is inactivated through hydrolysis by other esterases, it lacks nicotinic actions due to addition of methyl group, but doesn't have strong muscarinic activity. Its major actions are on smooth musculature of bladder and gastrointestinal tract. It has about 1 hour duration of action. Butanochol directly stimulates muscarinic receptors, causing increased intestinal motility and tone. It also stimulates the detrusor muscle of the bladder, whereas the trigone and sphincter muscles are relaxed. These effects stimulate urination. Therapeutic uses include in urological treatment, butanochol is used to stimulate chronic bladder, particularly in postpartum or post-operative non-obstructive urinary retention. Butanochol may also be used to treat neurogenic atony as well as megacolon. Adverse effects are generalized cholinergic stimulation with sweating, salivation, flushing, decreased blood pressure with reflex bradycardia, nausea, abdominal pain, diarrhea, bronchospasm. Atropine sulfate may be administered to overcome severe cardiovascular or bronchoconstrictor response to this agent. These are the adverse effects: diarrhea, diaphoresis, meiosis, nausea, and urinary urgency. Carbachol, carbamycholine has both muscarinic and nicotinic actions. Like butanochol, carbachol is an ester of carbamic acid and a poor substrate for acetylcholine esterase. It is biotransformed by other esterases, but at a much lower or slower rate. Actions include both cardiovascular and gastrointestinal system because of its ganglion stimulating activity, and it may first stimulate and then depress the system. It can cause release of epinephrine from adrenal medulla by its nicotinic action. Locally instilled into eye, immune action of acetylcholine causes meiosis and spasm of contraction in which eye ciliary muscle remains in constant state of contraction. Vision becomes fixed at some particular distance, making it impossible to focus. Opposing effects of atropine, a muscarine blocker on the eye. Therapeutic use includes its high potency, receptor non-selectivity, and relatively long duration of action. Carbachol is rarely used. Intraocular use provides meiosis for eye surgery and lowers intraocular pressure in the treatment of glaucoma. Adverse effects includes very less with ophthalmic use. Few adverse effects occur due to lack of systemic penetration, quaternary amine. So, untreated eye meiosis means contraction of the pupil. Eye treated with pilocarpine or carbachol. Mydriasis means dilatation or dilation of the pupil. Eye treated with atropine. Pilocarpine is also an alkaloid, is tertiary amine and is stable to hydrolysis by acetylcholine esterase. Compared with acetylcholine and its derivative, it is far less potent but is uncharged and can penetrate central nervous system at therapeutic doses. Pilocarpine exhibits muscarinic activity and is used primarily in ophthalmology. Actions include pilocarpine produces rapid meiosis, contraction of ciliary muscle, and spasm accommodation. Pilocarpine is one of the most potent stimulators of secretions such as sweat, tears, and saliva, but its use for producing these effects has been limited due to its lack of selectivity. Therapeutic uses include to treat glaucoma and its drug of choice for emergency lowering of intraocular pressure of both open angle and angle closure glaucoma. Extremely effective in opening the trabecular meshwork around the Schemal canal, causing an immediate drop in intraocular pressure because of increased drainage of aqueous humor. This action occurred within a few minutes, lasts 4 to 8 hours, and can be repeated. Topical carbonic anhydrase inhibitors such as dorzolamide and beta-adrenergic blockers such as timolol are effective in treating glaucoma but are not used for emergency lowering of intraocular pressure. The miotic action of pilocarpine is also useful in reversing mydriasis due to atropine. Drug is beneficial in promoting salivation in patients with xerostomia resulting from irradiation of head and neck. Sturgeon syndrome, characterized by dry mouth and lack of tears, is treated with oral pilocarpine tablets and civimeline, cholinergic drug that has drawback of being non-specific. Adverse effects include blood vision, night blindness, bro-H. Poisoning with this agent is characterized by exertion of various parasympathetic effects, including profuse sweating, diaphoresis, and salivation. Effects are similar to those produced by consumption of mushrooms of genus Inocybe, which contain muscarine. Parental atropine at doses that can cause cross the blood-brain barrier is administered to counteract toxicity of pilocarpine. Next is indirect acting cholinergic agonist, anticholinergic esterase agents, reversible. Acetylcholine esterase is an enzyme that specifically cleaves acetylcholine to acetate and choline and thus terminates its action, as shown in this figure. It is located both pre and post synaptically in nerve terminal where it is membrane bound. Acetylcholine esterase inhibitors or choline esterase inhibitors indirectly provide cholinergic action by preventing degradation of acetylcholine. This results in the accommodation of acetylcholine in synaptic space. Therefore, these drugs can provoke a response at all cholineroceptors, including both muscarinic and encoding receptors of autonomic nervous system, as well as at neuromuscular junction and in the brain. Reversible acetylcholine esterase inhibitors can be broadly classified as short-acting or intermediate-acting agents. Adrophonium is a prototype short-acting acetylcholinesterase inhibitor, binds reversibly to active center of acetylcholinesterase esterase, preventing hydrolysis of acetylcholine. It has short duration of action of 10 to 20 minutes due to rapid renal elimination. Endorphorium is a quaternary amine and its actions are limited to periphery. It is used in diagnosis of myasthenia gravis, autoimmune disease caused by antibodies to nicotinic receptors at neuromuscular junction. This causes degradation of nicotinic receptors, making fewer receptors available for interaction with acetylcholine. Intravenous injection of endorphorium leads to rapid increase in muscle strength in patients with myasthenia gravis. Care must be taken because excess drug may provoke cholinergic crisis. Atropine is antidote. Endorphorium may also be used to assess cholinesterase inhibitor therapy for differentiating cholinergic and myasthenic crisis and for reversing effects of non-depolarizing neuromuscular blockers after surgery. Due to availability of other agents, endorphorium use has become limited. Physostigmine is nitrogenous carbamic acid ester found naturally in plants and is tertiary amine. It is substrate for acetylcholine esterase and it forms relatively stable carbamylated intermediate with enzyme which then becomes reversibly inactivated. Result is potentiation of cholinergic activity throughout body. Actions include range effects and stimulate not only muscarinic and sites of autonomic nervous system but also nicotinic receptors of neuromuscular junction. Muscarinic stimulation can cause contraction of gastrointestinal smooth muscles, meiosis, bradycardia, and hypotension, as shown in the figure. Nicotinic stimulation can cause skeletal muscle twitches, fasciculations, and skeletal muscle paralysis at higher dose. Its duration of action is about 30 minutes to 2 hours, and it is considered an intermediate acting agent. Physostigmine can enter and stimulate cholinergic sites in central nervous system. Therapeutic uses include treatment of overdoses of drugs with anticholinergic actions such as atropine and to reverse effects of neuromuscular blockers. Adverse effects include high doses of physostigmine may lead to convulsions, bradycardia, and fall in cardiac output may also occur. Inhibition of acetylcholine esterase and neuromuscular junction causes accumulation of acetylcholine and ultimately, through continuous depolarization, results in paralysis of skeletal muscle. However, these effects are rarely seen with therapeutic doses. Next is indirect acting cholinergic agonists, anticholinesterase agents, reversible. Neostigmine is a synthetic compound that is also a carbonic acid ester and is reversibly inhibit acetylcholine esterase in a manner similar to physostigmine. Actions include, unlike physostigmine, neostigmine has a quaternary nitrogen, therefore it is a more polar, is absorbed poorly from gastrointestinal tract and does not enter central nervous system. Its effect on skeletal muscle is greater than physostigmine and it can stimulate contractility before it paralyzes. Neostigmine has an intermediate action duration of action, usually 30 minutes to 2 hours. Therapeutic use includes stimulate bladder and GI tract as an antidote for competitive neuromuscular blocking agents. Neostigmine is also used to manage symptoms of myasthenia gravis. Adverse effects of neostigmine include those of generalized cholinergic stimulation such as salivation, flushing, decreased blood pressure, nausea, abdominal pain, diarrhea, and bronchospasm. Neostigmine does not cause central nervous system side effects and is not used to overcome toxicity of central acting antimuscarinic agents such as atropine. Neostigmine is contraindicated when intestinal or urinary bladder obstruction is present. Pyridostigmine is another cholinesterase inhibitor used in chronic management of myasthenia gravis. Its duration of action is intermediate, 3 to 6 hours, but longer than that of neostigmine. Adverse effects are similar to those of neostigmine. Tacrine, donepezil, rivastigmine, and glantamine. Patients with Alzheimer's disease have a deficiency of cholinergic neurons and therefore lower levels of acetylcholine in central nervous system. This observation led to development of anticholinesterases as possible remedies for loss of cognitive function. Tacrine, first agent in this category, has been replaced by other because of its hepatotoxicity. Despite the ability of donepezil, rivastigmine, and glantamine to delay the progression of Alzheimer's disease, none can stop its progression. Gastrointestinal distress is the primary adverse effect. Indirect acting cholinergic agonist and T-cholinesterase esterase agent irreversible. Number of synthetic organophosphate compounds have ability to bind covalently to anti-cholinesterase esterase. The result is long-lasting increase in acetylcholine at all sites where it is released. Many of these drugs are extremely toxic and were developed by the military as nerve agents. Related compounds such as parathion and malathion are used as insecticides. Ecothiopate. Ecothiopate is a monophosphate that covalently binds via its phosphate group and active site of anti-cholinesterase. Once this occurs, enzyme is permanently inactivated and restoration of anticholinesterase activity requires synthesis of new enzyme molecules following covalent modification of anticholinesterase agents. Phosphorylated enzymes slowly release one of its ethyl group, loss of alkyl group, which is called aging, making it impossible for chemical activators such as paralidoxime to break bond between remaining drug and enzyme. Actions include generalized cholinergic stimulation, paralysis of motor function, causing breathing difficulties, and convulsions. Ecothiopate produces intense masses and thus has found therapeutic use. Intraocular pressure falls from facilitation of outflow of aqueous humor. Atropine in high dosage can reverse many of peripheral and some of central muscarinic effects of ecothiopate. Therapeutic uses include ophthalmic solution of drug is available for treatment of open-angle glaucoma. However, ecothiopate is rarely used due to its side effect profile, which include a risk of cataracts. This figure summarize action of some cholinergic agonists. So phosphorylation enzyme inactivated. And then we can see active sites of acetylcholinesterase, acetylcholinesterase inactive, acetylcholinesterase irreversibly inactive, acetylcholinesterase active. This figure summarizes some action of cholinergic agonist with Nicole, which is used in treatment of urinary retention, binds preferentially at muscarinic receptors. Carbachol binds to both muscarinic and nicotinic receptors, produces myasis during ocular surgery, used topically to reduce intraocular pressure in open angle or narrow angle glaucoma, particularly in patients who have become tolerant to pilocarpine. Pilocarpine reduces intraocular pressure in open angle and narrow angle glaucoma, binds preferentially at muscarinic receptors, uncharged tertiary amine that can penetrate the central nervous system. Physostigmine increases intestinal and bladder motility, reverses central nervous system and cardiac effects of tricyclic antidepressants, reverses central nervous system effects of atropine, uncharged tertiary amine that can penetrate CNS. Neostigmine prevents postoperative abdominal distension and urinary retention, used in treatment of myasthenia gravis, used as an antidote for comparative neuromuscular blockers, has intermediate duration of action from 0.5 to 2 hours. Adrophonium, used for diagnosis of myasthenia gravis, used as an antidote for comparative neuromuscular blockers, has short duration of action from 10 to 20 minutes. Rivastigmine, glutamine, donepezil, used as first-line treatment for Alzheimer's disease, though confers modest benefit, have not been shown to reduce healthcare cost or delay institutionalization. Can be used with memantine and methyl D-aspartate antagonists in moderate to severe disease. Ecothiopate, used in treatment of open-angle glaucoma, has long duration of action, 100 hours. Acetylcholine, used to produce myosis in ophthalmic surgery. This table shows the therapeutic uses and duration of action of cholinesterase inhibitors. Alcohols, hydrophonium, uses include myasthenia gravis, ileus, or arrhythmias. 5 to 15 minutes is duration of action. Carbamates and related agents, neostigmine and physostigmine, used for myasthenia gravis, ileus, myasthenia gravis, 0.5 to 2 hours, 3 to 6 hours. Myasthenia gravis, glaucoma, 0.5 to 2 hours. Ambinionium, myasthenia gravis, 4 to 8 hours. Dimicarium, glaucoma, 4 to 6 hours. Organophosphates, ecothiopate, used in glaucoma and has 100 hours of duration of action. This is a summary again. Bethanycol, we already read that mechanism of action include muscarinic agonists, negligible effect on nicotinic receptors, activate M1 through M3 receptors in non-peripheral tissues, causes increased secretion, smooth muscle contraction, except vascular smooth muscle relaxes, and changes in heart rate. Postoperative and neurogenic ileus and urinary retention, oral and parenteral duration, proteemia doesn't enter central nervous system, toxicity is excessive parasympathetic mimetic effects, especially bronchospasm asthmatics, interactions include additive with other parasympathomimetics. Carbachol, non-selective muscarinic and nicotinic agonist, otherwise similar to bethanycol, used typically topically almost exclusively for glaucoma. Direct-acting muscarinic alkaloid or synthetics, pilocarpine, like bethanycol, partial agonist, like bethanycol, glaucoma, Sjogren syndrome, oral lozenges and topical toxicity and interaction like bethanycol. Cevimeline, synthetic M3 selective, similar to pilocarpine. Direct-acting nicotinic agonist, nicotine agonist at both NN and NM receptors, activate autonomic post-ganglionic neurons, both sympathetic and parasympathetic and skeletal muscle, neuromuscular and plates, enter CNS and activate NN receptors. Medical use in smoking cessation, non-medical use in smoking and insecticides. Oral gum, patch for smoking cessation. Toxicity include increased gastrointestinal activity, nausea, vomiting, diarrhea, acutely increased blood pressure. High doses causes seizures, long-term gastrointestinal and cardiovascular risk factor. Interaction include additive with central nervous system stimulants. Varenicline, selective partial agonist at alpha-4 beta-2 nicotinic receptors used exclusively for smoking cessation. Short-acting cholinesterase inhibitor, alcohol, adrophonium. Alcohol binds briefly to active sites of acetylcholinesterase and prevents excess of acetylcholine. Amplifies all action of acetylcholine, increases parasympathetic activity and symptomatic neuromuscular transmission, diagnosis and acute treatment of myasthenia gravis. Parenteral porphyramine does not enter central nervous system. Toxicity, parasympathetic excess, interaction additive with parasympathomimetics. Intermediate acting cholinesterase inhibitors, carbamates, neostigmine, forms covalent bond with acetylcholinesterase, both hydrolyzed and released, like androphorium, but longer acting, myasthenia gravis, postoperative and neurogenic ileus, and urinary retention. Oral and parenteral pituitary amine doesn't enter central nervous system. Duration 2 to 4 hours. Toxicity interaction like aerophorium. Pyridoxyticmine like neostigmine, both longer action, 4 to 6 hours used in misthania. Pyridostigmine like neostigmine, but natural alkaloid tertiary amine enters central nervous system. Long-acting cholinesterase inhibitors, organophosphates, ecothiopate like neostigmine, but little more slowly, like neostigmine, but longer acting. Obsolete was used in glaucoma, topically only toxicity, BOAC, uveitis, blood vision. Malathion insecticide relatively safe for mammals and birds because metabolized by the enzyme to inactive products. Some medical use as ectoparasiticides. Parathion, others insecticide dangerous for all animals. Toxicity important because of agricultural use and exposure of farm workers. Serine, others nerve gas used exclusively in warfare and terrorism. So finally, toxicology of anticholinesterase agents. Irreversible anticholinesterase agents inhibits mostly organophosphate compounds are commonly used as agriculture insecticide in United States, which has led to numerous cases of accidental poisoning with these agents. In addition, they are frequently used for cidal and homicidal purposes. Organophosphate nerve gases such as serine are used as agents for warfare and chemical terrorism. Toxicity with these agents is manifested as necrotic and muscarinic signs and symptoms. Cholinergic crisis. Depending on agent, effects can be peripheral or can affect whole body. Reactivation of acetylcholine esterase. Pralidoxine, known as 2-PAM, can reactivate inhibited acetylcholinesterase. However, it is unable to penetrate central nervous system and therefore it is useful in treating central nervous system effects of organophosphate. Presence of a charged group allows it to approach an ionic site enzyme where it essentially displaces phosphate group of organophosphate and regenerate enzyme. If given before aging of alkylated enzyme occurs, it can reverse both muscarinic and peripheral effects of organophosphate, but not central nervous system effects. With newer nerve agents that produce aging of enzyme complex within seconds, pralidoxine is less effective. In addition, it cannot overcome toxicity of reversible anticholinesterase agents, inhibitors, for example, pyridostigmine. Other treatments, atropine is administered to prevent muscarinic side effects of these agents. Such effects include increased bronchial and ciliary secretion, bronchoconstriction, and bradycardia. Diazepam is also administered to reduce persistent convulsion caused by these agents. General supportive measures such as maintenance of patient airway, oxygen supply, and artificial respiration may be necessary as well. So let's start with cholinergic antagonist. Very interesting. So cholinergic antagonist is general term for agents that bind to cholinesterase, muscarinic or nicotinic, and prevent effect of acetylcholine and other cholinergic agonists. Most clinically useful of these agents are selective blockers of muscarinic receptors. They are commonly known as anticholinergic agents, a misnomer as they antagonize only muscarinic receptors. Anti-muscarinic agents, more accurate terminology, or parasympatholytics. Effects of parasympathetic innervation are thus interpreted by these agents and actions of sympathetic innervation are left unopposed. Second group of drugs in bionic blockers shows a preference of nicotinic receptors of sympathetic and parasympathetic ganglia. Clinically, they are least important cholinergic antagonists. Third family of compounds, neuromuscular blocking agents, mostly nicotinic antagonists, interfere with transmission of efferent impulses to skeletal muscle. These drugs are used as skeletal muscle relaxants in surgical anesthesia and as agents to facilitate intubation in surgical and critical care patients. The examples are antimuscarinic agents, ganglionic blockers, neuromuscular blockers. Antimuscarinic agents or anticholinergic drugs. These agents, for example, atropine and scopolamine, block muscarinic receptors, causing inhibition of muscarinic function. In addition, these drugs block few exceptional sympathetic neurons that are cholinergic, such as those innervating salivary and sweat gland, because they do not block nicotinic receptors. Anticholinergic drugs, more precisely, antimuscarinic drugs, have little or no action at skeletal neuromuscular junctions or autonomic ganglia. Anticholinergic drugs are beneficial in a variety of clinical situations. Number of antihistamines and antidepressants, mainly tricyclic antidepressants, also have antimuscarinic activity. Atropine is tertiary amine extracted from belladonna alkaloid. It has high affinity for muscarinic receptors and binds competitively to prevent acetylcholine from binding. Atropine acts both centrally and peripherally. General actions last about 4 hours. However, effects of topical administration in eye may persist for days. Neuroeffector organs have varying sensitivity to atropine. Greatest inhibitory effects are seen in bronchial tissue, salivary and sweat glands, and heart. Actions include atropine block muscarinic activity in eye, resulting in mydriasis, that is dilation of pupil, unresponsiveness to light, and cycloplegia, inability to focus for near vision. In patients with ankylosing glaucoma, intraocular pressure may rise generously. Gastrointestinal atropine as active isomer L-hyoscyamine can be used as antispasmodic to reduce activity of gastrointestinal tract. Atropine and scopolamine are probably the most potent antispasmodic drugs available. Although gastric motility is reduced, hydrochloric acid production is not significantly affected. Thus, atropine is not effective for treatment of for ulcers. Doses of atropine that produce spasm also reduce saliva secretion, ocular accommodation, and urination. These effects decrease compliance with atropine. Cardiovascular. Atropine produces divergent effects on cardiovascular system depending on dose. At low doses, predominant effect is slightly decrease in heart rate. This effect results from blockage of M1 receptors on inhibitors prejunctional or presynaptic neurons, thus permitting increased acetylcholine release. Higher doses of atropine causes progressive increase in heart rate by blocking M2 receptors on sinoatrial node. Secretions. Atropine block muscarinic receptors in salivary glands, producing dryness of mouth, xerostomia. Salivary glands are exclusively sensitive to atropine. Sweat and lacrimal glands are similarly effective. Inhibition of excretion of sweat glands can cause elevated body temperature, which can be dangerous in children and elderly. Therapeutic uses include topical atropine exerts both mydriatic and cycloplegic effects, and it permits measurement of effective errors without interference of by accommodative capacity of eye. Shorter acting antimuscarinics include cyclopentolate and tropicamide have largely replaced atropine due to prolonged mydriasis observed with atropine, 7 to 14 days versus 6 to 24 hours with other agents. Phenylephrine or similar alpha-adrenergic drugs are preferred for pupillary dilation if cycloplegia is not required. Antispasmodic agent to relax gastrointestinal tract. Injectable atropine is used to treat bradycardia for varying etiologies. Atropine is sometimes used as an anti-secretory agent to block secretions in the respiratory tract prior to surgery. Glycopyrrolate is also used for this indication. Antidote for cholinergic agonist. Treatment of organophosphate, insecticides, nerve gases, poisoning of overdose of clinically used anticholinesterase such as physostigmine, and in some types of mushroom poisoning, certain mushrooms contain cholinergic substances that block cholinesterases. Massive doses of injectable atropine may be required over a long period to counteract the poisons. Ability of atropine to enter central nervous system is of particular importance in treating central toxic effects of anticholinesterases. Pharmacokinetics. Atropine is readily absorbed, partially metabolized by liver and eliminated primarily in urine. It has a half-life of about 4 hours. Adverse effects include atropine may cause dry mouth, blurred vision, sandy eyes, tachycardia, urinary retention, and constipation. Effects on central nervous system include restlessness, confusion, hallucination, and delirium, which may progress to depression, collapse of circulatory and respiratory systems, and death. Lower doses of cholinesterases inhibitors such as physostigmine may be used to overcome atropine toxicity. Atropine may also induce troublesome urinary retention. Drug may be dangerous in children because they are sensitive to its effect, particularly to rapid increases in body temperature. So here we can see the competitive of scopolamine, atropine, and acetylcholine towards muscarinic receptor. Here we can see slight cardiac slowing, some dryness of the mouth, inhibition of sweating, rapid heart rate, palpitation, marked dryness of the mouth, dilatation of pupils, some blurring of near vision, and high hallucination and delirium, coma with a dose of atropine. As we increase dose of atropine, we will see these type of adverse effects. Scopolamine and the tertiary amine plant glycoside produces peripheral effects similar to those of atropine. However, scopolamine has greater action on central nervous system. Unlike atropine, central nervous system effects are observed at therapeutic doses and longer duration of action as compared to atropine. It has some special action as scopolamine is one of the most effective drugs available for motion sickness, as can be shown in this figure. It also has the unusual effect of blocking short-term memory. It contrasts to atropine. Scopolamine produces sedation, but at higher doses it can produce excitement. Scopolamine may produce euphoria and it's susceptible to abuse. Scopolamine is used for the prevention of motion sickness and post-operative nausea and vomiting. For motion sickness, it is available as topical patch that provides effects for up to 3 days. As with all drugs used for motion sickness, it is much more effective prophylactically than for treating motion sickness once it occurs. Pharmacokinetics and effects includes similar to those of atropine, with the exception of longer half-life. Aclidium, glycopyrrolate, ipratropium, and tiotropium. Ipratropium and priotropium are pottery derivatives of atropine and glycopyrrolate, and aclidinium are synthetic pottery compounds. Ipratropium is classified as short-acting muscarinic antagonist. Glycopyrrolate, tiotropium, and aclidium are classified as long-acting muscarinic antagonists based on the duration of action. These agents are approved as bronchodilators for maintenance treatment of bronchospasm associated with chronic obstructive pulmonary disease. Ipratropium and tiotropium are also used in acute management of bronchospasm in asthma and chronic management of asthma, respectively. All of these agents are delivered by inhalation. Because of positive charge, these drugs do not enter systemic circulation or central nervous system, restricting effects to pulmonary system. Propicamide and cyclopentolate. These agents are used as ophthalmic solutions for mydriasis and cycloplegia. Their duration of action is shorter than those of atropine. Propicamide produces mydriasis for 6 hours and cyclopentolate for 24 hours. Benztropine and trihexyphenidyl are useful as adjuvants with other anti-Parkinson agents to treat Parkinson's disease and other types of Parkinsonism syndromes, including antipsychotic-induced extrapyramidal symptoms. Oxybutinin and other anti-muscarinic agents for overactive bladder. Oxybutinin, deriphenacin, fesoterodine, solifenacin, tolterodine, and trospium are synthetic atropine-like drugs with anti-muscarinic actions. By competitive blocking muscarinic MC receptors in bladder, intravesical pressure is lowered, bladder capacity is increased, and frequency of bladder contraction is reduced. Anti-muscarinic agent actions at MC receptors in gastrointestinal tract, salivary glands, CNS, and eye may cause adverse effects. Deriphenacin and solifenacin are relatively more selective M3 muscarinic receptor antagonists. However, other drugs are mainly non-selective muscarinic antagonists, and binding to other muscarinic receptor subtypes may contribute to adverse effects. Therapeutic uses include management of overactive bladder and urinary incontinence. Oxybutinin is also used in patients with neurogenic bladder. Pharmacokinetics include availability in oral dosage forms. Most agents have a long half-life, which allows once daily administration. Immediate release, oxybutinin and tolterodine must be dosed 2 or more times daily. However, extended release formulation of these agents allow for once daily dosing. Oxybutinin is also available in a transdermal patch and topical gel formulation. These drugs are hepatically metabolized by cytochrome P450 system, primarily CYP 3A4 and 2D6, with the exception of trospium, which is thought to undergo ester hydrolysis. Adverse effects include dry mouth, constipation, and blood vision, which limit tolerability of these agents. Extended release formulations and transdermal patch have lower incidence of adverse effects and may be better tolerated. Trospium is quaternary compound that mainly crosses the blood-brain barrier and has fewer central nervous system effects than do other agents, making it preferred twice in treating overactive bladder in patients with dementia. This is a figure that shows the drug and their therapeutic uses. Trihexyphenidyl, benztropine, treatment of Parkinson's disease, management of antipsychotic-induced extrapyramidal effects. Deriphenacin, fesoterodine, oxybutinin, solifenacin, tolterodine, trospium is used for treatment of overactive urinary bladder. Cyclopentolate, propicamide, atropine in ophthalmology to produce mydriasis and cycloplegia prior to refraction. Atropine to treat spastic disorders of the gastrointestinal tract, to treat organ phosphate poisoning, to suppress respiratory secretions prior to surgery, to treat bradycardia. Scopolamine to treat or prevent motion sickness. Aclidinium, glycopyrrolate, ipratropium, tiotropium, treatment of COPD, ganglionic blockers, nicotine for smoking cessation. So these are the adverse effects commonly observed with muscarinic antagonists: blood vision, confusion, mydriasis, constipation, urinary retention. Ganglionic blockers specifically act on nicotinic receptors of both parasympathetic and sympathetic autonomic ganglia. Some also block ion channels of autonomic ganglia. These drugs show no selectivity towards parasympathetic or sympathetic ganglia and are not effective as neuromuscular antagonists. Thus, these drugs block entire output of autonomic nervous system at nicotinic receptors. Except for nicotine, other drugs mentioned in this category are non-depolarizing competitive antagonists. Responses of non-depolarizing blockers are complex and mostly unpredictable. Therefore, ganglionic blockage is rarely used therapeutically, but often served as a tool in experimental pharmacology. Nicotine, component of cigarette smoke. Nicotine is a poison with many undesirable actions. It is without therapeutic benefit and is delicious to our health. Depending on dose, nicotine depolarizes autonomic ganglia, resulting first in stimulation and then in paralysis of all ganglia. Stimulating effects are complex and result from increased release of neurotransmitters. As shown in this figure, due to effects on both sympathetic and parasympathetic ganglia. Dopamine, player, appetite suppression, norepinephrine, arousal, appetite suppression, acetylcholine, arousal, cognitive enhancement, glutamate, learning, memory enhancement, serotonin, mood modulation, appetite suppression, beta endorphin, reduction of anxiety and tension, GABA, that is GABA, aminobutyric acid, reduction of anxiety and tension. So these are the neurochemical effects of nicotine. Neuromuscular blocking agents. These drugs block cholinergic transmission between motor nerve endings and nicotinic receptors on skeletal muscles. They possess some chemical similarities to acetylcholine and act either as antagonist, non-depolarizing, or as agonist, depolarizing at receptors on end plate of neuromuscular junction. Neuromuscular blockers are clinically useful to facilitate rapid intubation when needed due to respiratory failure, rapid sequence intubation. During surgery, they are used to facilitate endotracheal intubation and provide some complete muscle relaxation at lower anesthetic doses. This increases safety and of anesthesia by allowing patients to recover quickly and completely. Neuromuscular blockers should not substitute for inadequate anesthesia. Neuromuscular blockers are also used in intensive care unit as adjuvant therapy to facilitate intubation and mechanical ventilation in critically ill patients. So, no depolarizing competitive blockers. First known neuromuscular blocker was curare, which Amazon hunters used to paralyze prey. Development of tubercularine followed by it has been replaced by agents with fewer adverse effects such as cisatracurium, mivacurium, pancuronium, rocuronium, and vancuronium. Let's see their mechanism of action. At low doses, neuromuscular blockers competitively block acetylcholine and nicotinic receptors, as shown in this figure. They compete with acetylcholine at receptor without stimulating it, thus preventing depolarization of muscle cell membrane and inhibiting muscular contraction. Their competitive action can be overcome by administration of cholinesterase inhibitors such as neostigmine and androphonium, which increase concentration of acetylcholine in neuromuscular junction. Clinicians employ this strategy to shorten duration of neuromuscular blockage. In addition, at low doses, muscle responds to direct electrical stimulation from peripheral nerve stimulator to varying degrees, allowing for monitoring of extent of neuromuscular blockage. At high doses, non-depolarizing agents can block ion channels of motor and plate. This leads to further weakening of neuromuscular transmission, reducing ability of cholinesterase inhibitors to reverse actions of non-depolarizing blockers, which complete blockage. Muscle does not respond to direct electrical stimulation. We can see that neuromuscular blocking drugs minimally absorb when given orally. Viricorium and rocuronium and metabolites appear mainly in bile. Pancuronium excreted primarily and obtained in urine. Actions include muscles have differing sensitivity to blockage of for competitive agents. Small, rapidly contracting muscles of face and eye are most susceptible and are paralyzed first, followed by fingers, limbs, neck, and tongue muscles. Next, intercostal muscles are effective and lastly diaphragm. Muscles recover in reverse manner. Sugammadex is selectively relaxant binding agent that terminates action of both rocuronium and vancuronium and can be used to speed recovery. Pharmacokinetics are neuromuscular blockers are injected intravenously or occasionally intramuscularly. These agents possess two or more quaternary amines in their bulky ring structure that prevent absorption from gut. They penetrate membranes with very poorly and do not enter cells or cross blood-brain barrier. Drug action is terminated in variety of ways. Pancuronium is excreted until in urine. Caesareum undergoes organ-independent metabolism via Hoffman elimination to laudanocin, which is further metabolized and renally excreted. Aminosteroid drugs, vicurinium and leucurinium are deacetylated in liver and excreted until in bile. Mivacurinium is eliminated by plasmacholinesterase. Choice of agent depends on desired onset and duration of muscle relaxation and route of elimination. The characteristics are mentioned here. The red color is time to maximum blockage in minutes, and yellow is time to recover 25% of maximum response in minutes. So we can see that the Caesatriconium spontaneously degrades plasma. It is often used in patients with multi-system organ failure because its metabolism is independent of hepatic or renal function. Is useful in mechanical ventilation of critical patients. Vagalolytic increased heart rate. And last, postoperative muscle pain is common. Hyperkalemia and increased intraocular and intragastric pressure may occur. Drug may trigger malignant hyperthermia. Rapid onset makes succinylcholine useful for tracheal intubation in patients with gastric contents. Adverse effects are minimum. Drug interaction includes cholinesterase inhibitors. Drugs such as neostigmine, physostigmine, pyridoxytigmine, erdrophonium can overcome action of depolarizing neuromuscular blockers. However, with increased dosage, cholinesterase inhibitors can cause depolarizing block due to elevated acetylcholine concentration at end plate membrane. If neuromuscular blockers has entered ion channels, is bound to receptors. Cholinesterase inhibitors are not as effective in overcoming blockage. Halogenated hydrocarbon anesthetics, drugs such as desflurane act to enhance neuromuscular blockage by exerting stabilizing action at neuromuscular junction. These agents stabilize neuromuscular junction to effects of neuromuscular blockers. Aminoglycoside antibiotics such as gentamicin and tobramycin inhibit acetylcholine release from cholinergic nerves by competing with calcium ions. They synergize with competitive blockers, enhancing neuromuscular blockage. Calcium channel blockers, these agents may really increase neuromuscular blockage of competitive blockers. Depolarizing agents work by depolarizing the plasma membrane of the muscle fiber, similar to action of acetylcholine. However, these agents are more resistant to degradation by acetylcholinesterase and can more persistently depolarize the muscle fiber. Succinylcholine is only depolarizing muscle relaxant in use today. Mechanism of action: succinylcholine attaches to nicotinic receptor and acts like acetylcholine to depolarize the junction as shown in figure. Unlike acetylcholine, which is instantly destroyed by acetylcholinesterase, the depolarizing agent persists at high concentration in the synaptic cleft, remaining attached to the receptor enough for a longer time and providing sustained depolarization of the muscle cell. The duration of action is dependent on diffusion from the motor end plate and hydrolysis by plasma cholinesterase, also called butyryl cholinesterase or pseudocholinesterase. Genetic variants in which plasma cholinesterase levels are low or absent lead to prolonged neuromuscular paralysis. The depolarizing agent first causes opening of the sodium channel associated with nicotinic receptors, which results in depolarization of receptor phase 1, as shown in figure this. This leads to transient twitching of the muscle, fasciculation. Continued binding of the depolarizing agents renders the receptors incapable of transmitting further impulses with time. Continuous depolarization gives way to gradual depolarization as the sodium channel closes or is blocked. This causes a resistance to depolarization, as shown in phase 2, and flaccid paralysis. Actions: as with competitive blockers, the respiratory muscles are paralyzed first. Succinylcholine initially produces brief muscle fasciculation that has caused muscle soreness. This may be prevented by administering a small dose of non-depolarizing neuromuscular blockers prior to succinylcholine. Normally, the duration of action of succinylcholine is excessively short due to rapid hydrolysis by plasma cholinesterase. However, succinylcholine that reaches the neuromuscular junction is not metabolized, allowing the agent to bind to nicotinic receptors, and redistribution to plasma is necessary for metabolism. Therapeutic uses: because of its rapid onset of action, succinylcholine is useful where rapid endotracheal intubation is required. It is also used during electroconvulsive shock treatment. Pharmacokinetic include injected intravenously. Brief duration of action results from redistribution and rapid hydrolysis by plasma cholinesterase. Drug effectively rapidly disappear upon discontinuation. Adverse effects include hyperthermia because of potentially induced malignant hyperthermia in susceptible patients, apnea, administration of acetylcholine to a patient who is deficient in plasma cholinesterase or has atypical form of the enzyme can lead to prolonged apnea due to paralysis of the diaphragm. Rapid release of potassium may also contribute to prolonged apnea in patients with electrolyte imbalances. In patients with electrolyte imbalances receiving digoxin or diuretics, such as heart failure patient, sustained choline should be used consciously or not at all. Hyperkalemia Increased calcium release from intracellular stores. This may be particularly dangerous in burn patients and patients with massive tissue damage in which calcium has rapidly lost, or in patients with renal failure. This is a table shows properties of neuromuscular blocking agents. So only succinylcholine is depolarizing agents. All others are not depolarizing agents. So first, minimum release of histamine. Other varies, and in other cases none. Ganglionic block is none. Low. Propancurinium is medium. Others are also low. Effects reversed by cholinesterase inhibitors. In succinylcholine is not possible, but others are yes. Duration of action 5 to 10 minutes. Others intermediate, long in pancurinium, and intermediate in also. So plasma, route of elimination, butyl cholinesterase, plasma esterases, spontaneous chemical degradation, pancurinium renal excretion. Others are similar. Biliary and renal excretion, or biliary and renal excretion with hepatic metabolism. So this is a summary. Motion sickness drugs, scopolamine, unknown mechanism of action, reduces vertigo, postoperative nausea, prevention of motion sickness and postoperative nausea and vomiting, transdermal patch used for motion sickness, intramuscular injection for postoperative use. Toxicity includes tachycardia, blood vision, xerostomia, delirium, interaction with other antimuscarinics. Gastrointestinal disorders, diaclomine, competitive antagonist at MP3 receptors, reduces smooth muscle and security activity of gut, irritable bowel syndrome, minor diarrhea, available in oral and parenteral form, short half-life, but actions last up to 6 hours. Toxicity include tachycardia, confusion, retention, increased intraocular pressure, interaction include with other antimuscarinics, iostigmine, longer duration of action, glycopyrrolate, similar to diclofenac, ophthalmology, atropine, competitive antagonism, and all muscarinic receptors, causes mydriasis and cycloplegia, retinal elimination, prevention of synesthesia after surgery, use as drops long 5 to 6 days, action, toxicity, increase intraocular pressure in closed angular glaucoma, interactions with other antimuscarinics. So others, scopolamine, faster onset of action with than atropine, homatropine, shorter duration action, 12 to 24 hours, cyclopentolate, shorter duration action, 3 to 6 hours, tropicamide, shortest duration of action, 15 to 60 minutes. Respiratory asthma, COPD, ipratropium, competitive non-selective antagonist at M receptors, reduces or prevents bronchospasm, prevention and relief of acute episode of bronchospasm, aerosol, canister up to rate, toxicity, xerostomia, cough, interactions with other antimuscarinics, urinary oxybutynin, slightly MC-selective muscarinic antagonist, reduces smooth muscle tone spasm, urge, incontinence, post-operative spasm, oral intravascular, intravenous, oral intravenous patch formulation, toxicity, tachycardia, constipation, increased blood pressure, xerostomia, patch, pruritus, interactions with other antimuscarinics, danifacine, solifenacin, and tolithirodine, tertiary amines with somewhat greater selectivity for M3 receptors, tropismium, quaternium with less CNS effect, cholinergic poisoning, atropine, non-selective competitive antagonists at all muscarinic and receptors in CNS and periphery, block muscarinic access at exocrine glands, heart, smooth muscle, mandatory antidote for severe cholinesterase inhibitor poisoning, intravenous infusion until antimuscarinic sign appear, continue at long as toxicity insignificant as long as acetylcholinesterase inhibition continues. Pralidoxine, very high affinity for phosphorus atom, but does not enter CNS, regenerate actives, acetylcholinesterase, can release skeletal muscle and plate block, and usual antidote for early stage 48 hours, cholinesterase inhibitor poisoning, intravenous every 4 to 6 hours, toxicity can cause muscle weakness in overdose. So basically, ACHE is acetylcholinesterase, CNS is central nervous system, COPD is chronic obstructive pulmonary disease. Let's continue with antinergic agonists. These are the drugs that affect receptors that are stimulated by norepinephrine, noradrenaline, or epinephrine adrenaline. These receptors are known as adrenergic receptors or adrenoceptors. Drugs that activate adrenergic receptors are termed sympathomimetics, and that block activation of adrenergic receptors are termed sympatholytics. Some sympathomimetics directly activate adrenergic receptors, direct acting agonists, while others act indirectly by enhancing release or blocking reuptake of norepinephrine, indirect acting agonists. Agents that act directly or indirectly stimulate adrenoceptors are shown in this figure. Adrenergic neurons release norepinephrine as primary neurotransmitters. These neurons are found in central nervous system and in sympathetic nervous system, where they serve as a link between ganglia and effector organs. Adrenergic drugs act on adrenergic receptors located either presynaptically on neuron or postsynaptically on effector organs, as shown in this figure. So properties of adrenergic, dopamine, and imidazoline receptors. So alpha 1, alpha 2, alpha, we have their mechanism of action and their effects. So effects are contraction of smooth muscles, exocrine gland secretion, neuronal excitation, alpha 2, inhibition of norepinephrine release, decrease in secretion of aqueous humor, decrease in secretion of insulin, platelet aggregation, and central nervous system effects. Beta 1, increase in secretion of renin and increase in heart rate, contractility, and conduction. Beta 2, glycogenolysis, relaxation of smooth muscles, and uptake of potassium in skeletal muscles. Beta 3, lipolysis, thermogenesis in skeletal muscle, uterine relaxation, and other effects. Dopamine receptors, D1, relaxation of muscle smooth muscle. D2, modulation of neurotransmission in the sympathetic and central nervous systems. Imidazoline receptors, natriuresis, and decrease of sympathetic outflow from the central nervous system. Now let's see the neurotransmission in adrenergic neurons. Closely resembles that described for cholinergic neurons, except that norepinephrine is neurotransmitter instead of acetylcholine. Neurotransmission involves following steps: synthesis, storage, release, and receptor binding of norepinephrine, followed by removal of neurotransmitter from synaptic gap. So let's see the figure 1, this figure on the left-hand side. First step is synthesis of norepinephrine. Tyrosine is transported by a carrier into the adrenergic neuron, where it is hydroxylated to dihydroxyphenylalanine by tyrosine hydroxylase. This is a rate-limiting step in the formation of norepinephrine. Then decarboxylated by the enzyme aromatic L-amino acid decarboxylase to form dopamine in the presynaptic neuron. Step 2 is storage of non-epinephrine in vesicles. Dopamine is then transported into synaptic vesicles by an amine transporter system. This carrier system is blocked by reserpine. Next, dopamine is hydroxylated to form norepinephrine by the enzyme dopamine beta hydroxylase. Third step is the release of norepinephrine. An action potential arriving at the nerve junction triggers an influx of calcium ions from the extracellular fluid into the cytoplasm of the neuron. The increase in calcium causes synaptic vesicles to fuse with the cell membrane and to undergo exocytosis and expel their contents into the synapse. Drugs such as guanethidine block this release. Step 4 is binding to receptors. Non-epinephrine released from the synaptic vesicle diffuses into the synaptic space and binds to postsynaptic receptors on the effector organs or to presynaptic neurons receptors or the nerve ending. Binding of norepinephrine in a receptor triggers a cascade of events within the cell, resulting in the formation of intercellular second messengers that act as links, transducers in the communication between the neurotransmitter and the action generated within the effector cell. Adrenergic receptors use both the cyclic adenosine monophosphate second messenger system and the phosphatidyl inositol cycle to transduce the signal into an effect. Norepinephrine also binds to presynaptic receptors, mainly alpha 2 subtype, that modulate the release of neurotransmitter. Step 5 is removal of norepinephrine. Norepinephrine may diffuse out of the synaptic space and enter the systemic circulation, be metabolized to inactive metabolites by catechol or methyl transferase in the synaptic space, or undergo reuptake back into the neuron. Reuptake by the neural membrane involves a sodium chloride dependent non-norepinephrine transporter that can be inhibited by tricyclic antidepressants such as imipramine, by serotonin norepinephrine reuptake inhibitors such as duloxetine, or by cocaine. Reuptake of norepinephrine into the presynaptic neuron is the primary mechanism of combination of its effects. The last step is potentiation or potential phase of recaptured norepinephrine. So once norepinephrine re-enters the adrenergic neuron, it may be taken up into synaptic vesicles via the amine transporter system and be sequestered for release by another action potential, or it may persist in a protected pool in the cytoplasm. Alternatively, norepinephrine can be oxidized by monoamine oxidase present in neuronal mitochondria. So this table shows the adrenoceptor types and subtypes. Alpha 1 type, the agonist is phenylephrine, antagonist is prazosin. Alpha 2 type, agonist is clonidine, antagonist is yohimbine. Effect is decreased CAM, common to all. Beta type, isoproterenol, propranolol is the antagonist, increase in CAM, common to all. Beta 1, dobutamine, antagonist is betaxolol. Beta 2, albuterol is agonist. Butoxamine is antagonist. Dopamine type, dopamine. D1, phenol, the palm, increase in CAM, and other D2, opposite action, decrease in CAM, bromocriptine. Adrenergic receptors or adrenoceptors. In the synaptic nervous system, several classes of adrenoceptors can be distinguished pharmacologically. Two main families of receptors, designated alpha and beta, are classified based on receptors response to adrenergic agonist, epinephrine, norepinephrine, and isoproterenol. Both alpha and beta receptor types have number of specific receptor subtypes. Alterations in primary structure of receptors influence their affinity for various agents. Alpha receptors show a weak response to synthetic agonists, isoproterenol, but they are responsive to naturally occurring catecholamines, epinephrine or norepinephrine, as shown in this figure. For alpha receptors, rank order of potency is more epinephrine, then norepinephrine, then isoproterenol. And in the other case is opposite. Alpha adrenoceptors are divided into two subtypes, alpha 1 and alpha 2, based on their affinities for alpha agonists and antagonists. Alpha 1 receptors have higher affinity for phenylephrine than alpha 2 receptors. And drug clonidine selectively binds to alpha 2 receptors and has less effect on alpha 1 receptors. Alpha 1 receptors, these receptors are present on postsynaptic membrane of affected organs and mediate mainly of classic effects. Originally designated as alpha-adrenergic, involving constriction of smooth muscle, activation of alpha 1 receptors initiate a series of reactions through G protein activation of phospholipase C, ultimately resulting in generation of second messengers inositol 1,4,5 triphosphate IP3 and diacylglycerol DAG. Inositol 1,4,5 triphosphate initiate release of calcium from endoplasmic reticulum into cytosol, and DAG turns on other proteins within cell as shown in this figure. Alpha 2 receptors are located primarily on sympathetic presynaptic nerve endings and control release of norepinephrine. When sympathetic adrenergic nerve is stimulated, portion of release norepinephrine circles back and reacts with alpha 2 receptors on presynaptic membrane. Stimulation of this receptor causes feedback inhibition and inhibits further release of norepinephrine from stimulated adrenergic neurons. This inhibitory action serves as local mechanism for modulating norepinephrine output when there is high sympathetic activity. In this instance, by inhibiting other further output of norepinephrine from adrenergic neuron, these receptors are acting as inhibitory autoreceptors. Alpha 2 receptors are also found on presynaptic, parasympathetic neurons. Norepinephrine released from presynaptic sympathetic neurons can diffuse to and interact with these receptors, inhibiting acetylcholine release. In these instances, these receptors are behaving as inhibitory heteroreceptors. This is another mechanism to modulate autonomic activity in a given area. In contrast to alpha 1 receptors, effects of binding at alpha 2 receptors are mediated by inhibition of adenine cyclase and by all fall in levels of intracellular CAM. Further subdivision, alpha 1 and alpha 2 receptors are further divided into alpha 1A, alpha 1B, alpha 1C, alpha 1D, and into alpha 2A, alpha 2B, alpha 2C. This extended classification is necessary for understanding selectivity of some drugs. For example, tamsulosin is a selective alpha 1A antagonist that is used to treat benign prostatic hyperplasia. Drugs has fewer cardiovascular side effects because it targets 1A subtype receptors found primarily in urinary tract and prostate gland and does not affect alpha 1B subtype found in blood vessels. Beta adrenoceptors differ from those of alpha receptors and are characterized by strong response to isoproterenol, which less sensitivity to epinephrine and norepinephrine. For beta receptors, the rank order of potency is first isoproterenol, then epinephrine, then norepinephrine. Beta adrenoceptors can be subdivided into three major subgroups, beta 1, beta 2, beta 3, based on their affinities for adrenergic agonists and antagonists. Beta 1 receptors have approximately equal affinities for epinephrine and norepinephrine, where beta 2 receptors have higher affinity for epinephrine than for norepinephrine. The tissues with a predominance of B2 receptors, such as vasculature of skeletal muscle, are particularly responsive to effects of circulating epinephrine released by adrenal medulla. Binding of neurotransmitter at any of three types of beta receptor results in activation of adenyl cyclase and increased concentrations of CAM within the cell. Distribution of receptors, adrenergically innervated organs and tissues usually have predominant type of receptors. For example, tissues such as vasculature of skeletal muscle have both alpha-1 and beta-2 receptors, but beta-2 receptors predominate. Other tissues may have one type of receptors almost exclusively. For example, heart contains predominantly beta-1 receptors. The characteristics responses mediated by adrenal receptors include physiologic response to adrenal stimulation according to receptor type, because many drugs preferentially stimulate or block one type of receptors. This figure summarizes most prominent effects mediated by adrenal receptors. As generalization, stimulation of alpha-1 receptors characteristically produces vasoconstriction, particularly in skin and abdominal viscera, and increases in total peripheral resistance and blood pressure. Stimulation of beta-1 receptors characteristics causes cardiac stimulation, increases heart rate and contractility, whereas stimulation of beta-2 receptors produces vasodilation in skeletal muscle, vascular beds, and smooth muscle relaxation. Beta-3 receptors are involved in lipolysis along with beta-1 and also has effects on retrocessor muscle of bladder. Desensitization of receptors. Prolonged exposure to catecholamine reduces responsiveness of these receptors. This phenomenon known as desensitization. The three mechanisms have been suggested to explain this phenomenon. So, number one is sequestration of receptors so that they are unavailable for interaction with ligand. Number two, downregulation, that is disappearance of receptors either by destruction or by decreased synthesis. Number three is inability to couple to G protein because receptor has been phosphorylated or cytoplasmic site. Characteristic of adrenergic agonist. Most adrenergic drugs are derivatives of beta-phenylethylamine, as shown in this figure. Substitution on benzene ring or on ethylamine side chain produce variety of compounds with varying abilities to differentiate between alpha and beta receptors and to penetrate CNS. Two important structural features of these drugs are number and location of OH, substitution on benzene ring, and two, nature of substituents on amino nitrogen. Drug containing catechol ring are shown in yellow. Catecholamines. Sympathomimetic amines that contain 3,4-dihydroxy benzene groups such as epinephrine, norepinephrine, isoproterenol, and dopamine are called catecholamines. These compounds share the following properties: high potency, indirectly activating alpha or beta receptors. Rapid inactivation, catecholamines are metabolized by catechol over methyl transferase post-synaptically by monoamine oxidase intraneurally, by catechol over methyl transferase and monoamine oxidase in gut wall, and by monoamine oxidase in liver. Catecholamines have only brief period of action when given parenterally, and they are ineffective when administered orally. They have poor penetration into central nervous system. Catecholamines are polar and therefore do not readily penetrate into central nervous system. Most catecholamines have some clinical effects, anxiety, tremor, and headaches that are attributable to action on central nervous system. Non-catecholamines, these are compounds lacking catechol hydroxyl groups, have longer half-life because they are not inactivated by the COMT. These include phenylephrine, ephedrine, and amphetamine. These agents are poor substrates for monoamine oxidase, an important route of metabolism, and thus show prolonged duration of action, increased lipid solubility of many non-catecholamines due to lack of polar hydroxyl groups, permits greater access to central nervous system. Substitution on amine nitrogen. Nature of substituents on amine nitrogen is important in determining beta selectivity of adrenergic agonists. For example, epinephrine within CH3 substituent on amine group nitrogen is more potent at beta receptors than norepinephrine, which has an unsubstituted amine. Similarly, isoproterenol, which has an isopropyl substituent CH3 on amine nitrogen, is strong beta agonist with little alpha affinity. Mechanism of action. Direct acting agonists directly act on alpha and beta receptors, producing effects similar to those that occur following stimulation of sympathetic nerves or release of epinephrine from adrenal medulla. Examples include epinephrine, norepinephrine, isoproterenol, dopamine, and phenylephrine. Indirect acting agonists include the agents that block reuptake of norepinephrine or cause release of norepinephrine from cytoplasmic pools or vesicles of adrenergic neuron. Then transverses synapse and binds to alpha or beta receptors. Examples of reuptake inhibitors agents that cause norepinephrine release include cocaine and amphetamine, respectively. Mixed action agonists include ephedrine and its stereoisomer pseudoephedrine. Both stimulate adrenoceptor directly and enhance release of norepinephrine from adrenergic neuron, as this shown in this figure. So basically, drug enhances release of epinephrine from vesicles. Indirect action, mixed action drug act both directly and indirectly, and direct action include drug directly activate receptors. Direct acting adrenergic agonists bind to adrenergic receptors on effector organs without interacting with presynaptic neuron. As a group, these agents are widely used in clinical practice. Ephedrine is one of 4 catecholamines: epinephrine, norepinephrine, dopamine, and dopamine, commonly used in therapy. Firstly, a naturally occurring neurotransmitter, and later is synthetic compound. In adrenal medulla, norepinephrine is methylated to yield epinephrine, which is stored in chromaffin cells along with norepinephrine. On stimulation, adrenal medulla releases about 80% epinephrine and 20% norepinephrine directly into circulation. Epinephrine interacts with both alpha and beta receptors. At low doses, beta effects vasodilation on vascular system predominate, whereas at high doses, alpha effects vasoconstriction are the strongest. Actions on cardiovascular system is the epinephrine strengthens contractility of myocardium, positive inotrope, beta 1 action, and increase its rate of contraction. Positive conotrope, beta 1 action, therefore cardiac output increases. These effects increase oxygen demand on myocardium. Epinephrine activates beta 1 receptors on kidney to cause renin release. Renin is an enzyme involved in production of angiotensin II, a potent vasoconstriction. Epinephrine constricts arterioles in skin, mucous membrane, and viscera. Alpha effects, and it dilates vessels going to liver and skeletal muscle. Beta 2 effects. These combined effects results in a decrease in renal blood flow. Therefore, cumulative effect is an increase in systolic blood pressure, coupled with a slight decrease in diastolic pressure due to beta 2 receptor mediated vasodilation in skeletal muscle vascular bed, as shown in this figure. Epinephrine causes powerful bronchodilation by acting directly on blocking smooth muscle beta 2 action. It also inhibits release of allergy mediators such as histamine from mast cells. Hyperglycemia. Epinephrine has a significant hyperglycemic effect because of increased glycogenolysis in liver, beta 2 effect, increased release of glucogen, beta 2 effect, and a decreased release of insulin, alpha 2 effect. Lipolysis. Epinephrine initiates lipolysis through agonist activity on beta receptor of adipose tissue. Increased levels of KAPS stimulate a hormone-sensitive lipase which hydrolyzes triglycerides to free fatty acids and glycerol. Therapeutic uses include epinephrine is primarily drug used in emergency treatment of respiratory conditions when bronchoconstriction has resulted in diminished respiratory function. In treatment of anaphylactic shock, epinephrine is a drug of choice and can be life-saving in this setting. Within a few minutes after subcutaneous administration, respiratory function greatly improves. Anaphylactic shock. Epinephrine is the drug of choice for treatment of type 1 hypersensitivity reactions, including anaphylaxis in response to allergens. Cardiac arrest. Epinephrine may be used to restore cardiac arrhythmia, cardiac rhythm in patients with cardiac arrest. Local anesthesia. Local anesthetic solution may contain low concentration, for example, 1 into 100,000 parts of epinephrine. Epinephrine greatly increases the duration of local anesthesia by producing vasoconstriction at the site of injection. Epinephrine also reduces systemic absorption of the local anesthetic and promotes local hemostasis. Intraocular surgery. Epinephrine is used in the induction and maintenance of mydriasis during intraocular surgery. As you can see, aerosol, intramuscular, intravenous, subcutaneous injection, poor penetration into CNS, metabolizes appear in urine. Pharmacokinetics. Epinephrine has a rapid onset but a brief duration of action due to rapid degradation. Preferred route of anaphylaxis in outpatient setting is intramuscular anterior thigh due to rapid absorption. In emergencies, epinephrine is given intravenously for most rapid onset of action. It may also be given subcutaneously by endotracheal tube or by inhalation. It is rapidly metabolized by monoamine oxidase and COMT and metabolites metanaphrine and vinyl mandelic acid are excreted in urine. Adverse effects can produce adverse CNS effects that include anxiety, fear, tension, headache, and tremor. It can trigger cardiac arrhythmias, particularly if patient is receiving digoxin. Epinephrine can also induce pulmonary edema due to increased afterload caused by vasoconstrictive properties of drug. Patient with hyperthyroidism may have an increased production of adrenergic receptors in vasculature, leading to an enhanced response to epinephrine. And those must be reduced in these individuals. Inhalation anesthetics also sensitize heart to effects of epinephrine, which may lead to tachycardia. Epinephrine also increases the release of endogenous stores of glucose. In diabetic patients, dosages of insulin may have to be increased. Non-selective beta blockers prevent vasodilatory effects of epinephrine on beta 2 receptors, leaving alpha receptor stimulation unopposed. This may lead to increased peripheral resistance and increased blood pressure. Norepinephrine is neurotransmitter in adrenergic neurons. It should theoretically stimulate all types of adrenergic reactions, receptors. However, when administered in therapeutic doses, alpha adrenergic receptor is most affected. The cardiovascular actions include vasoconstriction. Norepinephrine causes a rise in peripheral resistance due to intense vasoconstriction of most vascular beds, including kidney alpha-1 effect. Both systolic and diastolic blood pressure increase. Norepinephrine causes greater vasoconstriction than epinephrine because it does not induce compensatory vasodilation via beta-2 receptors on blood vessels supplying skeletal muscle. Weak beta-2 activity of norepinephrine also explains why it is not useful in treatment of Broca's wall anaphylaxis. Baroreceptor reflex. Norepinephrine increases blood pressure and this stimulates baroreceptor, inducing a rise in vagal activity. Increased vagal activity produces a reflex bradycardia, which is sufficient to counteract local actions of norepinephrine on heart, although reflex compensation does not affect positive inotropic effects of drug. When atropine, which blocks transmission of vagal effects, is given before norepinephrine, stimulation of heart by norepinephrine is evident as tachycardia. Therapeutic uses include to treat shock, septic shock, because it increases vascular resistance and therefore increases blood pressure. It has no other clinically significant uses. Pharmacokinetics include it is given IV for rapid onset of action. Duration of action is 1 to 2 minutes. Following end of infusion, it is rapidly metabolized by MOA and COMT, and inactive metabolites are excreted in urine. Adverse effects are similar to epinephrine. In addition, norepinephrine is a potent vasoconstrictor and may cause blanching and slouching of skin along an injected vein. If extravasation, leakage of drug from the vessel into the tissue surrounding the injection site occurs, it can cause tissue necrosis. It should be administered in peripheral veins. If possible, impaired circulation from norepinephrine may be treated with alpha receptor antagonist phentolamine. Alternatives to phentolamine include intradermal terbutaline and topical nitroglycerin. Isoproterenol is a direct-acting synthetic catecholamine that stimulates both beta-1 and beta-2 adrenergic receptors. Its non-selectivity is disadvantage and reason why it is rarely used therapeutically. Its action on alpha receptor is insignificant. Isoproterenol produces intense stimulation of heart, beta-1 effect, increasing heart rate, contractility, and cardiac output. It is an active as epinephrine in this action. Isoproterenol also dilutes arterioles of skeletal muscle beta-2 effect, resulting in decreased peripheral resistance because of its cardiac stimulatory action. It may increase systolic blood pressure, resulting in decreased peripheral resistance. Because of its cardiac stimulatory action, it may increase systolic blood pressure slightly, but it greatly reduces mean arterial and diastolic blood pressure. Isoproterenol is also a potent bronchodilator, beta-2 effect. Adverse effects of isoproterenol are similar to beta receptor effect related side effects of epinephrine. Dopamine, immediate metabolic precursor of norepinephrine, occurs naturally in central nervous system, in basal ganglia, where it functions as the neurotransmitter, as well as in anterior medulla. Dopamine can activate 85 beta adrenergic receptors. For example, at higher doses, it causes vasoconstriction by activating alpha-1 receptors, whereas low doses, it stimulates beta-1 cardiac receptors. In addition, D1 and D2 dopaminergic receptors, distinct from alpha-1 and beta adrenergic receptors, occur in peripheral mesenteric and renal vascular beds, where binding of dopamine produces vasodilation. D2 receptors are also found on presynaptic adrenergic neurons, where their activation interferes with norepinephrine release. Actions include dopamine exerts a stimulatory effect on beta-1 receptors of heart, having both positive inotropic and chronotropic effects. At very high doses, dopamine activates alpha-1 receptors on musculature, resulting in vasoconstriction. Renal and visceral dopamine relates with renal and splanching arterioles by activating dopaminergic receptors, thereby increasing blood flow to kidneys and other viscera. These receptors are not affected by alpha or beta blocking drugs, and in past low dose, renal dose, dopamine was often used in prevention or treatment of acute renal failure. However, most recent data suggests that there is limited clinical utility in renal protective effects of dopamine. This figure shows that isoproterenol causes vasodilation but strongly increases cardiac force and rate. Isoproterenol causes a significant decrease in peripheral resistance, also causes markedly decreased diastolic pressure with moderately increased systolic pressure. Therapeutic uses include cardiogenic for and septic shock and given by continuous infusion. It raises blood pressure by stimulating beta-1 receptors on heart to increase cardiac output and alpha-1 receptors on blood vessels to increase total peripheral resistance. It enhances perfusion to kidney and splanchnic areas, increase blood flow to kidney, enhancing glomerular filtration rate and causes diuresis. By contrast, norepinephrine can diminish blood supply to kidney and may reduce renal function. Dopamine is also used to treat hypertension, severe heart failure, and bradycardia, unresponsiveness to other treatments. Adverse effects include overdose produces some effects as sympathetic stimulation is rapidly metabolized by MAO and CMT, and its adverse effects, nausea, hypertension, and arrhythmias are therefore short-lived. Phenol-dopam is agonist of peripheral dopamine D1. Separate is used as a rapid acting vasodilator to treat severe hypertension. Hypertension in hospitalized patients acting on coronary arteries, kidney arterioles, and mesenteric arteries. This is a racemic mixture, and R isomer is the active component. It undergoes extensive first-pass metabolism, has 10-minute elimination half-life after intravenous infusion. Headache, flushing, dizziness, nausea, vomiting, and tachycardia due to vasodilation may occur with this agent. Next is dobutamine. It is synthetic direct-acting catecholamine that is primarily beta-1 receptor agonist with minor beta-2 and alpha-1 effects. It increases heart rate and cardiac output with few vascular effects. It is used to treat or increase cardiac output in acute heart failure as well as for inotropic support other after cardiac surgery. Drug increases cardiac output and does not elevate oxygen demands of myocardium as much as other pathomimetic drugs. It should be used with caution in arterial fibrillation because it increases atrioventricular conduction. Other effects are similar to epinephrine. Tolerance may develop with prolonged use. Oxymetazoline is direct-acting synthetic adrenergic agonist that stimulate both alpha-1 and alpha-2 adrenergic receptors. It is found in many other over-the-counter nasal spray decongestants, as well as in ophthalmic drops for relief of redness of eyes associated with swimming, colds, and contact lenses. It directly stimulates alpha receptors on blood vessels, supplying nasal mucosa and conjunctiva, thereby producing vasoconstriction and decreasing congestion. It is absorbed in systemic circulation regardless of route of administration and may produce nervousness, headaches, and trouble sleeping. Local irritation and sneezing may occur with intranasal administration. Use for greater than 3 days is not recommended as rebound congestion and dependence may occur. Phenylephrine is direct-acting synthetic adrenergic drug that binds primarily to alpha-1 receptors. Is a vasoconstrictor that raises both systolic and diastolic blood pressure. It has no effect on heart itself, but rather it induces reflex bradycardia when given parenterally, making it useful in treatment of paroxysmal supraventricular tachycardia. Drug is used to treat hypertension in hospitalized or surgical patients, especially those with a rapid heart rate. Large doses can cause hypertensive headache and cardiac irregularities. Phenylephrine acts as a nasal decongestant when applied topically or taken orally, although data suggests it may not be as effective. Phenylephrine has replaced pseudoephedrine in many oral decongestants since pseudoephedrine has been misused to make methamphetamine. Phenylephrine is also used in ophthalmic solution for mydriasis. Midodrine, a prodrug, is metabolized to pharmacologically active dysglycomidorine. It is selective to alpha-1 agonist, which acts in periphery to increase arterial and venous route. It is indicated for treatment of orthostatic hypotension. Drugs should be given 3 times daily with doses at 3 or 4 hour intervals to avoid spine hypertension. Doses within 4 hours of bedtime are not recommended. Clonidine is an alpha-2 agonist used for treatment of hypertension. It can also be used to minimize symptoms of withdrawal from opiates, tobacco, smoking, and benzodiazepine. Both clonidine and alpha-2 agonist guanfacine may be used in management of attention deficit hyperactivity disorder. Clonidine acts centrally on presynaptically alpha-2 receptors to produce inhibition of sympathetic vasomotor centers, decreasing sympathetic outflow to the periphery. Most common side effects of clonidine are lethargy, sedation, constipation, xerostomia. Abrupt discontinuation must be avoided to prevent rebound hypertension. Albuterol, metoprolol, and terbutaline are short-acting beta agonists used primarily as bronchodilators and administered by metered dose inhaler. Albuterol is for the management of acute asthma symptoms because it is more selective for beta-2 receptors than metoprolol. Inhaled terbutaline is no longer available in the United States, but is still used in other countries. Injectable terbutaline is used half-label as a uterine laxant to suppress premature labor and is used for its indication. Should not exceed 72 hours. One of the most common side effects of these agents is tremor, but patients tend to develop tolerance to this effect. Other side effects include restlessness, apprehension, and anxiety. When these drugs are administered orally, they may cause tachycardia or arrhythmia due to beta 1 receptor activation, especially in patients with underlying cardiac disease. Monoamine oxidase inhibitors also increase the risk of adverse cardiovascular events, and concomitant use should be avoided. Salmeterol, formoterol, R-formoterol, and RR enantiomer are formoterol and inducterol are long-acting selective agonists used for the management of respiratory disorders such as asthma and chronic obstructive pulmonary disease. A single dose by immediate dose inhalation device such as dry powder inhaler provides sustained bronchodilation over 12 hours compared with less than 3 hours for albuterol. Unlike formoterol, however, salmeterol has somewhat delayed onset of action. Long-acting beta receptors, long-acting beta 2 selective agonists are not recommended as monotherapy for treatment of asthma because they have been shown to increase risk of asthma-related deaths. However, these agents are highly efficacious when combined with asthma controller medication such as an inhaled corticosteroid. Mirabegron is a beta-3 agonist that relaxes smooth muscle and increases bladder capacity. It is used for patients with overactive bladder. It may increase blood pressure and should not be used in patients with uncontrolled hypertension. It increases levels of dioxin and inhibits CYP2D6 isozyme, which may enhance effects of other medications metabolized by this pathway, for example, metoprolol. So this is the red color shows onset of bronchodilation. Blue color shows the duration of bronchodilation. Epinephrine, terbutaline, albuterol, arformoterol, formoterol, and salmeterol with the high duration of bronchodilation. Indirect acting adrenergic agonists cause release, inhibit reuptake, or inhibit the degradation of epinephrine or norepinephrine. They potentiate effects of epinephrine or norepinephrine produced endogenously but do not directly affect postsynaptic receptors. Amphetamine, the marked central stimulatory action of amphetamine is often mistaken by drug abusers as its only action. However, drug can also increase blood pressure significantly by alpha-1 agonist action on vasculature as well as beta-1 stimulatory effects on heart. Its action are mediated primarily through increase in non-vesicular release of catecholamines such as dopamine and non-epinephrine from nerve terminals. Tyramine is not clinically useful drug, but it is important because it is found in fermented foods such as aged cheese and Chianti wine. It is normal byproduct of tyrosine metabolism. Normally, it is oxidized by monoamine oxidase in gastrointestinal tract, but if patient is taking monoamine oxidase inhibitors, it can precipitate serious vasopressor episodes. Like amphetamines, tyramine can enter nerve terminals and displace stored norepinephrine. The release catecholamines then act on adenoreceptors. Cocaine is unique among local anesthetics in having ability to block sodium chloride dependent norepinephrine transporter required for cellular uptake for norepinephrine into adrenergic neuron. Consequently, norepinephrine accumulates in synaptic space, resulting in enhanced sympathetic activity and potentiation of actions of epinephrine and norepinephrine. Therefore, small doses of catecholamines produces greatly manifested effects in individual taking cocaine. In addition, the duration of action of epinephrine and norepinephrine is increased. Like amphetamines, it can increase blood pressure by alpha-1 agonist action and beta stimulatory effects. Cocaine as a drug of abuse. In the end, mixed action adrenergic agonists. Ephedrine and pseudoephedrine are mixed action adrenergic agents. They not only enhance release of stored norepinephrine from nerve endings, but also directly stimulate both alpha and beta receptors. Wide variety of adrenergic actions ensure that are similar to those of epinephrine, although less potent. The both are not catecholamines and are poor substrate for COMT and MAO. Therefore, these drugs have a long duration of action. Ephedrine and pseudoephedrine have excellent absorption after oral administration and penetrate central nervous system, but pseudoephedrine has fewer CNS effects. Ephedrine is eliminated largely unchanged in urine, and pseudoephedrine undergoes incomplete hepatic metabolism before elimination in urine. Ephedrine raises systolic and diastolic blood pressure by vasoconstriction and cardiac stimulation, and it is indicated in anesthesia-induced hypotension. Ephedrine produces bronchodilation, but it is less potent and slower acting than ephedrine or isotretinoin. It was previously used to prevent asthma attack, but has been replaced by more effective medication. Ephedrine produces mild stimulation of central nervous system. This increases alertness, decreases fatigue, and prevents sleep. It also improves athletic performance. Clinical use of ephedrine is declining because of availability of better, more potent agents that cause fewer adverse effects. Ephedrine containing herbal supplements, mainly ephedra containing products, have been banned by United States Food and Drug Administration because of life-threatening cardiovascular reactions. Oral pseudoephedrine is primarily used to treat nasal and sinus congestion, and pseudoephedrine has been illegally used to produce methamphetamine. Therefore, products containing pseudoephedrine have certain restrictions and must be kept behind the sales counter in the United States. The effects are arrhythmias, headache, hyperactivity, insomnia, nausea, and tremors. This table shows the pharmacologic effects and clinical use of adrenergic agonists. So direct acting catecholamines, dobutamine. The use is cardiogenic shock, acute heart failure, and cardiac stimulation during heart surgery. Dopamine, cardiogenic shock, septic shock, heart failure, and adjuvant to fluid administration in hypovolemic shock. Epinephrine, anaphylactic shock, cardiac arrest, ventricular fibrillation, a reduction in bleeding during surgery, and prolongation of the action of local anesthetic. Isoproterenol, atrioventricular block and bradycardia. Norepinephrine, hypotension and shock. Direct-acting non-catecholamines, albuterol, asthma, clonidine, short-term control of intraocular pressure, clonidine, hypertension, opioid dependence, dexmedetomidine, adjunct to anesthesia, midodrine, orthostatic hypotension, oxymetazoline, nasal and ocular decongestion, phenylephrine, nasal and ocular decongestion, mydriasis, maintenance of blood pressure and treatment of shock, terbutaline, asthma, premature labor. Indirect acting agents include amphetamine, narcolepsy, attention deficit disorder, cocaine, local anesthesia. Mixed acting agents, ephedrine, nasal decongestion, pseudoephedrine, also nasal decongestion. So dopamine is a catecholamine with mixed action. So this is again a summary of the drugs, midodrine, and we can see that they have orthostatic hypertension, clonidine, hypertension, dobutamine, cardiogenic shock, acute heart failure, albuterol, asthma, phenolphthalein, hypertension, bromocriptine, Parkinson's disease, and prolactamine. This figure shows the tissue serotype, action, and opposing actions. So, for example, heart, beta 1, increase automaticity, increase conduction velocity, automaticity, increase conductility, atomicity. So these are the effects. And also these are the drugs, specific receptors and therapeutic uses, which we have already seen. Epinephrine, anaphylactic shock, cardiac arrest, local anesthetics to increase duration of action. Norepinephrine, treatment of shock. Isoproterenol as a cardiac stimulant. Dopamine, treatment of shock, treatment of congestive heart failure, raises blood pressure. Dobutamine, treatment of acute heart failure. They all considered catecholamines, rapid onset of action, brief duration of action, not administered orally, do not penetrate blood-brain barrier. Oxymetazoline as a nasal decongestant for relief eye redness. Phenylephrine as a nasal decongestant, raise blood pressure, treatment of paroxysmal supraventricular tachycardia. Clonidine, treatment of hypertension. Albuterol, metaproterenol, terbutaline, treatment of bronchospasm, short-acting. R4-metirol, formoterol, indacatemor, salmeterol, treatment of bronchospasm, long-acting. Amphetamine as a central nervous system stimulant in treatment of children with attention deficit narcolepsy and for appetite control. Ephedrine, pseudoephedrine raise blood pressure as a nasal decongestion, and they are considered non-catecholamines compared to catecholamines. Long duration of action, all can be administered orally via inhalation. Let's continue with adrenergic antagonist. Adrenergic antagonists or adrenergic blockers or sympatholytics bind to adrenoreceptors but do not trigger usual receptor-mediated cellular effects. These drugs act by either reversibly or irreversibly attaching to adrenoreceptors, thus preventing activation by endogenous or exogenous agonists. Like the agonists, the adrenergic antagonists are classified according to their relative affinities for alpha or beta receptors in the sympathetic nervous system. Alpha adrenergic blocking agents antagonize subtypes of alpha adrenergic receptors, alpha 1 and alpha 2, depending on specificity of agent for receptor subtype. Drugs will block alpha 1 adrenoreceptors profoundly affect blood pressure because normal separate control of vasculature occurs in large part through agonists Action on alpha-1 adrenergic receptors. Blockage of these receptors reduces sympathetic tone of blood vessels, resulting in decreased peripheral vascular resistance. This lowered blood pressure induces reflex tachycardia. Magnitude of response depends on sympathetic tone of individual when agent is given. Selective alpha-2 adrenergic blockers have limited clinical utility. So number one is phenoxybenzamine, which is non-selective, non-competitive blocker of alpha-1 and alpha-2 adrenergic receptors. Actions include this drug prevents alpha-1 receptor vasoconstriction of peripheral blood vessels caused by endogenous catecholamines, which leads to decreased peripheral resistance and resultant reflex tachycardia. However, by blocking presynaptic alpha-2 receptors on sympathetic nerve terminals in heart, phenoxybenzamine causes increase in release of norepinephrine, which in turn increases heart rate and cardiac output, mediated by beta-1 receptors. This may also lead to cardiac arrhythmias and anginal pain. This drug has been unsuccessful in maintaining lowering blood pressure and hypertension, and it is no longer used for this purpose. Epinephrine reversal. All alpha adrenergic blockers reverse alpha agonist of epinephrine. Vasoconstrictive effects of epinephrine is interrupted by vasodilation of other vascular beds caused by stimulation of beta-2 receptors is not blocked. In response to phenoxybenzamine, systemic blood pressure decreases. In response to epinephrine, actions of norepinephrine are not reversed by are diminished because norepinephrine lacks significant beta agonist action or vasculature. Phenyloxybenzamine has no effect on actions of isoproterenol, which is pure beta agonist. So let's continue with therapeutic uses. Phenoxybenzamine is used in treatment of swelling, sweating, and hypertension associated with pheochromocytoma. Catecholamine secreting tumor of cells derived from renal medulla. Phenoxybenzamine is sometimes effective in treating Raynaud disease and frostbite. Adverse effects include they cause postural hypotension, nasal stiffness, nausea, and vomiting. It may inhibit ejaculation. It may induce reflex tachycardia, which is mediated by a baroreceptor reflex. Phenoxybenzamine should be used with caution in patients with cerebrovascular or cardiovascular disease. Phentolamine produces a competitive block of alpha-1 and alpha-2 receptors. The effect lasts for approximately 4 hours. After a single injection, pharmacological effects of phentolamine are very similar to those of phenoxybenzamine. It is used for diagnosis and short-term management of pheochromocytoma. It's also used locally to prevent dermal necrosis following extravasation of epinephrine. Phentolamine is useful to treat hypertensive crisis due to abrupt withdrawal of clonidine or injection of pyramine containing food in patient taking monoamine oxidase inhibitors. Prazosin, and rhodopsin are selective competitive blockers of alpha-1 receptor in contrast to phenoxybenzamine, and phentolamine. They are useful in treatment of hypertension. Tamsulosin, alfuzosin, and cellulosin are examples of other selective alpha-1 antagonists indicated for treatment of benign prostate hyperplasia. Metabolism leads to inactive bioproducts that are excreted in urine except for those of doxazosin, which appear in feces. Doxazosin is longest acting of these drugs. Mechanism of action includes these drugs decrease peripheral resistance and lower blood pressure by causing relaxation of both arterial and venous smooth muscle, like phenoxybenzamine and phentolamine. These drugs cause minimal changes in cardiac output, renal blood flow, and glomerular filtration rate. Tamsulosin and alfuzosin and cellulosin have less profound effects on blood pressure because they are less selective for alpha-1b receptors found in blood vessels and more selective for alpha-1a receptors in prostate and bladder. Blockage of alpha-1a receptors decrease tone in smooth muscle of both bladder neck and prostate, improves urine flow. So we can see here alpha-adrenergic blockers have no effect on the action of isoproterenol, which is a pure beta agonist. Alpha-adrenergic blockers reverse the vasoconstrictive action of epinephrine. So this is a summary of effect of adrenergic blockers on changes in blood pressure induced by isoproterenol, epinephrine, and norepinephrine. Therapeutic uses. Individuals with elevated blood pressure treated with those drugs do not become tolerant to this action. However, first dose of this drugs may produce exacerbated orthostatic hypertensive response, as shown in this figure, that can result in syncope, fainting. This action term first dose effect may be minimized by adjusting first dose to 1/3 or 1/4 of normal dose and by giving drug at bedtime. These drugs may cause modest improvement in lipid profile and glucose metabolism in hypertensive patients because of inferior cardiovascular outcomes as compared to those other antihypertensive alpha-1 antagonists are not as used as monotherapy for treatment of hypertension. Adverse effects include alpha-1 blockers such as prazosin and duxosin may cause dizziness, lack of energy, nasal congestion, headache, drowsiness, and other orthostatic hypertension, although to lesser degree they are observed with phenoxybenzamine and phentolamine. Additive antihypertensive effect occurs when alpha-1 antagonists are given with vasodilators such as nitrates or PDE5 inhibitors, for example, sildenafil, thereby necessitating cautious dose titration and use at lowest possible doses. These agents may cause floppy iris syndrome, a condition in which iris billows in response to intraoperative eye surgery. Figure summarize some adverse effects include orthostatic hypertension, tachycardia, dizziness and headache, sexual dysfunction. Yohimbine is selective competitive alpha-2 blocker that works at level of central nervous system to increase sympathetic outflow to periphery. It is found at component of bark of yohimbe tree, Posinia stalia yohimbe, and has been used as sexual stimulant and in treatment of erectile dysfunction. Its use in treatment of these disorders is not recommended due to lack of demonstrated efficacy. Beta-adrenergic blocking agents. All of clinically available beta blockers are competitive antagonists. Non-selective beta blockers act at both beta-1 and beta-2 receptors, whereas cardioselective beta antagonists primarily block beta-1 receptors. There are no clinically useful beta-2 selective antagonists. These drugs are also differ in intrinsic sympathomimetic activity, CNS effects, blockage of sympathetic receptors, vasodilation, and pharmacokinetics, as shown in this figure. Although all beta blockers lower blood pressure, they do not induce postural hypertension because alpha-adrenal receptors remain functional. Therefore, normal sympathetic control of vasculature is maintained. Beta blockers are effective in treating systemic as well as portal hypertension, angina, cardiac arrhythmias, myocardial infarction, heart failure, hypothyroidism, and glaucoma. They are also used for prophylaxis of migraine headaches. Names of all beta blockers end in olol except for labetalol and carvedilol. So start with propranolol. Is a prototype non-selective beta antagonist and blocks both beta-1 and beta-2 receptors with equal affinity. Sustained release preparations for once a day dosing are available. Non-selective beta blockers, including propranolol, have ability to block actions of isoproterenol, beta-1, beta-2 agonist on cardiovascular system. Thus, in absence of beta blocker, isoproterenol does not produce cardiac stimulation. Beta-1 mediated or reductions in mean arterial pressure and diastolic pressure. Beta-2 mediated. In presence of non-selective beta blocker, epinephrine no longer lowers diastolic blood pressure or stimulates heart, but its vasoconstrictive action mediated by alpha receptors remains unimpaired. Actions of non-epinephrine or cardiovascular system are mediated primarily by alpha receptors and are therefore most unaffected. Cardiovascularly diminishes cardiac output, having both negative inotropic and chronotropic effect. It directly depresses sinoatrial and atrioventricular nodal activity, resulting bradycardia. Usually limits drug dose during exercise or stress when sympathetic nervous system is activated. Beta blockers attenuate expected increase in heart rate, cardiac output, workload, and oxygen consumption are decreased by blockage of beta-1 receptors, and these effects are useful in treatment of angina. Beta blockers are effective in attenuating supraventricular cardiac arrhythmias, but generally are not effective against ventricular arrhythmias except those used by exercise. Peripheral vasoconstriction. Non-selective blockage of beta receptors prevent beta-2 mediated vasodilation skeletal muscle, increasing peripheral vascular resistance. Reduction in cardiac output produced by all beta receptor blockers leads to decreased blood pressure, which triggers reflex peripheral vasoconstriction. That is reflected in reduced blood flow to periphery. In patients with hypertension, total peripheral resistance returns to normal or decreases with long-term use of propranolol as a result of down-regulation of beta receptors. There is gradual reduction on both systolic and diastolic blood pressures in hypertensive patients. Bronchoconstriction, blocking beta-2 receptors in lungs of susceptible patients causes contraction of bronchial smooth muscle. As shown in this figure, this can precipitate exacerbation in patients with chronic obstructive pulmonary disease or asthma. Therefore, beta blockers, particularly non-selective ones, are contraindicated in patients with asthma and should be avoided in chronic obstructive pulmonary disease. Disturbances in glucose metabolism. Beta blockage leads to decreased glycogenolysis and decreased glucogen secretion. Therefore, propranolol is given to diabetic patient receiving insulin. Careful monitoring of blood glucose is essential because pronounced hypoglycemia may occur after insulin injection. Beta blockers offer also attenuate normal physiologic response to hypoglycemia. Diaphoresis with hypoglycemia still occurs, as this is mediated through the neurotransmitter acetylcholine. Therapeutic uses include hypertension. Propranolol does not reduce blood pressure in people with normal blood pressure, lowers blood pressure in hypertension by several different mechanisms of action. Decreased cardiac output is primary mechanism, but inhibition of renin release from kidney, decrease in total resistance with long-term use, and decreased sympathetic outflow from central nervous system also contribute to antihypertensive effects. Angina pectoris. Propranolol decreases oxygen requirement of heart muscle and therefore is effective in reducing chest pain or exertion. It is common in angina. Propranolol is therefore useful in management of chronic stable angina. Myocardial infarction. Propranolol and other beta blockers have protective effects on myocardium. Thus, patients with have had one myocardial infarction seem to be protective against second heart attack by prophylactic use of beta blockers. In addition, administration of beta blockers immediately following myocardial infarction reduces infarct size and early mortality. Mechanism of these effects have maybe reduction in action of circulating catecholamines that increase oxygen demand in elderly, already ischemic heart muscle. Propranolol also reduces incidence of sudden arrhythmic death after myocardial infarction. Migraine. Propranolol is effective in reducing migraine episodes when used prophylactically. It is one of the most useful blockers for this indication due to its lipophilic nature that allows it to penetrate CNS. For acute management of migraines, serotonin agonists such as sumatriptan are used as well as other drugs. Hyperthyroidism. These drugs and other beta blockers are effective in blunting widespread sympathetic stimulation that occurs in hyperthyroidism. In acute hyperthyroidism, thyroid strong beta blockers may be life-saving in protecting against serious cardiac arrhythmias. Pharmacokinetics include after oral administration, propranolol is almost completely absorbed. It is subject to first plasma effect, and only about 25% of administered dose reaches circulation. Volume of distribution of propranolol is quite large, 4 liters per kg, and drug readily crosses blood-brain barrier due to its high lipophilicity. Propranolol is extensively metabolized, and most metabolites are excreted in urine. Adverse effects include bronchoconstriction, fatigue, sexual dysfunction, arrhythmias upon abrupt withdrawal. Treatment with beta blocker must never be stopped abruptly because of risk of respiratory cardiac arrhythmia, which may be severe. Beta blocker must be tapered off gradually over a period of at least a few weeks. Long-term treatment with beta blocker, beta antagonist leads to upregulation of beta receptors. Upsuppression of therapy, increased receptors can precipitate worsened angina or hypertension through action of endogenous catecholamines or upregulation of beta receptors. Sexual impairment, impaired sexual activity have been reported in male patient taking propranolol. Reasons of this are not clear and may be independent of beta receptor blockage. However, beta blockers do not affect ejaculation mediated by alpha receptors. Metabolic disturbances. Beta blockage leads to decreased glycogenolysis and decreased glucagon secretion. Fasting hypoglycemia may occur. In addition, beta blockers can prevent counter-regulatory effects of catecholamines during hypoglycemia. Thus, perception of symptoms of hypoglycemia such as tremor, tachycardia, and nervousness are blunted by beta blockers. Major role of beta receptors is to mobilize energy molecules such as free fatty acids. Lipases in fat cells are activated mainly by beta receptors stimulation, leading to metabolism of triglycerides into free fatty acids. Patient-administered non-selective beta blockers may have increased triglycerides and reduced high-density lipoprotein, good cholesterol through beta blockage. These effects on serum lipid profile may be less pronounced with the use of beta-1 selective antagonists such as metoprolol. CNS effects includes depression, dizziness, lethargy, fatigue, weakness, visual disturbances, hallucinations, short-term memory loss, emotional lability, vivid dreams, including nightmares and depression. Fever, central nervous system effects may be seen with more hydrophilic beta blockers, for example, atenolol, because they do not cross blood-brain barrier as readily. Drug interaction include with that drugs that interfere with or inhibit metabolism of propranolol, such as simvastatin, fluoxetine, paroxetine, and ritonavir, may potentiate its antihypertensive effects. Conversely, those that stimulate or induce its metabolism, such as barbiturates, phenytoin, and rifampin, can decrease its effects. Non-selective beta blockers, such as propranolol, may prevent rescue effects of epinephrine in anaphylaxis. Netrolol and timolol, non-selective beta antagonists, also blocks beta-1 and beta-2 receptors and are more potent than propranolol. Netrolol has a very long duration of action, as shown in this figure. Timolol reduces production of aqueous humor in eye. It is used typically topically in treatment of chronic and open-angle glaucoma. Treatment of glaucoma, beta blockers such as topically applied trimelol are effective in diminishing intraocular pressure in glaucoma. This occurs by decreasing secretion of aqueous humor by ciliary body. Cartililol, levobunolol, metoprolol are non-selective beta antagonists, whereas beta-oxazolol is beta-1 selective agent. Unlike cholinergic drugs, these agents neither affect ability of eye to focus for near vision nor change pupil size. When administered intraocularly, onset is about 30 minutes and effects last for 12 to 24 hours. Beta blockers are only used for chronic management of glaucoma. In acute attack of glaucoma, pilocarpine is still drug of choice for emergency lowering of intraocular pressure. Other agents used in treatment of glaucoma are summarized in this figure. So class of drug, beta adrenergic, antagonist topical, beta-oxazolol, cartilol, levobunolol, metoprolol, timolol. Mechanism of action include decrease of aqueous humor production, side effects, ocular irritation, contraindicated in patient with asthma, obstructive airway disease, bradycardia, and congestive heart failure. Alpha-adrenergic agonist, topical, apraclonidine, brimonidine, decrease of aqueous humor production and increase of aqueous humor outflow, red eye and ocular irritation, reactions, malaise, and headache. Cholinergic agonist, topical, pilocarpine, carbachol, increase of aqueous outflow, eye or brow pain, increase myopia, and decrease vision. Prostaglandin-like analog, topical, latanoprost, travoprost, bimaproprost, increase of aqueous humor outflow. Red eye and ocular irritation, increased iris pigmentation, and excessive hair growth of eyelashes. Carbonic anhydrase inhibitors, topical and systemic. Dorzolamide and brinzolamide, topical, and acetazolamide and methalozolamide, oral. Decrease of aqueous humor production, transient myopia, nausea, diarrhea, loss of appetite, taste, and renal stones, oral drugs. Acebutolol, atenolol, betaxolol, bisoprolol, esomorolol, metoprolol, and nebivolol. These all are selective beta-1 antagonists. Drugs that preferentially block beta-1 receptor minimize unwanted bronchoconstriction, beta-2 effect seen with use of non-selective agents in asthma patients. Cardioselective beta blockers such as acebutolol, atenolol, and metoprolol antagonize beta-1 receptor at doses 50 to 100-fold less than those required to block beta-2 receptors. This cardioselectivity is most pronounced at low doses and is lost at high doses. Because beta-1 selectivity of these agents is lost at high doses, they may antagonize beta-2 receptors. Actions: these drugs lower blood pressure in hypertension and increase exercise tolerance in angina. Esmolol has a very short half-life due to metabolism of ester linkage. It is only available intravenously and is used to control blood pressure or heart rhythm in critically ill patients and those undergoing surgery or diagnostic procedures. In addition to its cardioselective beta blockage, nebivolol releases nitric oxide from endothelial cells and causes vasodilation. In contrast to propranolol, cardioselective beta blockers have fewer effects on pulmonary function, peripheral resistance, and carbohydrate metabolism. Nevertheless, asthma patients treated with these agents must be carefully monitored to make certain that respiratory activity is not compromised because these drugs have less effect on peripheral vascular beta-2 receptors. Coldness of extremities, renowned phenomena, common side effects of beta blocker is less frequent. Therapeutic use include cardio-selective beta blockers are useful in hypertensive patients with impaired pulmonary function. These agents are also first-line therapy for chronic stable angina. Bisoprolol and extended-release formulation of metoprolol are indicated for management of chronic heart failure. Acebutolol and pindolol antagonists with partial agonist activity. Acebutolol, beta-1 selective antagonist, pindolol, non-selective beta blocker are not pure antagonists. These drugs can also weakly stimulate block beta-1 and beta-2 receptors and are said to have ICA. These partial agonists stimulate beta receptor to which they are bound, yet they inhibit stimulation by a more potent endogenous catecholamines. Epinephrine and norepinephrine result of these opposing actions is diminished effect on reduction of cardiac rate and cardiac output compared to that of beta blockers without ISA. Decreased metabolic effects. Beta blockers with ISA minimize disturbances of lipid and carbohydrate metabolism that are seen with other beta blockers. For example, these agents do not decrease plasma HDL levels. Therapeutic use includes in hypertensive patients with moderate bradycardia because further decrease in heart rate is less pronounced with these drugs. Beta blockers with ISA are not used for stable angina or arrhythmias due to their partial agonist effect. Overall, beta blockers are infrequently used in clinical practice. This figure summarizes the indication of some beta blockers. Hypertension, propranolol, metoprolol, and other beta blockers reduce cardiac output and secretion. Glaucoma, timolol, and other beta blockers reduce secretion of aqueous humor. Migraine, propranolol provides a prophylactic effect. Thyrotoxicosis, propranolol reduces cardiac rate and potential for arrhythmias. Arrhythmias prophylaxis after pyrocolic infarction. Propranolol and metoprolol reduce cardiac output and renin secretion. Supraventricular tachycardia, propranolol and esmolol slow atrioventricular conduction velocity. Angina pectoris, propranolol, nadolol, and other beta blockers reduce cardiac rate and force. Labetalol, carvedilol are antagonists of both alpha and beta adenoreceptors. Labetalol and carvedilol counteract alpha-1 blocking actions that produce vasodilation, thereby reducing blood pressure. They contrast with other beta blockers that produce initial peripheral vasoconstriction, and these agents are therefore useful in treating hypertensive patients for whom increased peripheral vasodilation is undesirable. Carvedilol also decreases rapid per oxidation and vascular wall thickening, effects that have benefit in heart failure. Therapeutic use in hypertension and heart failure. Labetalol is used as alternative to levodopa in treatment of pregnancy-induced hypertension. Intravenous labetalol is also used to treat hypertensive emergencies because it can rapidly lower blood pressure. Beta blocker should not be given to patients with acute exacerbation of heart failure as they can worsen the condition. However, carvedilol as well as metoprolol and bisoprolol are beneficial in patients with stable chronic heart failure. These agents work by blocking the effect of sympathetic stimulation on heart, which causes worsening heart failure over time. As we can see, agonists, for example, epinephrine, antagonists, for example, propranolol, partial agonists, for example, pindolol and acebotenol. Adverse effects include orthostatic hypotension and dizziness are associated with alpha-1 blockage. And as we can see, this figure summarizes separate specificities and uses of beta-adrenergic antagonist. This figure summarizes beta-adrenergic antagonist. So drug propranolol used for hypertension, migraine, hyperthyroidism, and angina pectoris, myocardial infarction, nadolol, pindolol for hypertension, timolol, glaucoma, hypertension, atenolol, bisoprolol, esmolol, metoprolol, hypertension, angina, myocardial infarction, atrial fibrillation, acebutol, hypertension, neobitalol, hypertension, carvedilol, labetalol for hypertension. So this is the summary of beta-adrenergic antagonist. So again, this is a figure showing a table showing the mechanism, pharmacological effect, and clinical use of selected adrenoreceptor antagonists. So again, alpha blockers, alfuzosin, tamoxifenolin. So they are the competitive alpha-1 blockers, relax bladder, urethral and posterior smooth muscle, doxycycline, prazosin, tazocin, competitive alpha-1 blocker, cause vasodilation, decrease blood pressure, relax bladder, urethral and posterior smooth muscle, phenoxybenzamine, non-competitive alpha-1, alpha-2 blocker, causes vasodilation, decrease blood pressure, phentolamine, competitive alpha-1 and alpha-2 blocker, cause vasodilation, decreases vascular resistance and blood pressure, beta blocker, acebutolol, decreases cardiac rate, output, we know conduction and O2 demand, decreases blood pressure. Atenolol, esmolol, metoprolol, nadolol, pindolol, propranolol all have the same as acebutolol. Only timolol decreases cardiac rate, output, AV node, conduction, and O2 demand, decreases blood pressure, but also decreases intraocular pressure. Alpha and beta blockers, carvedilol, causes vasodilation, decreases heart rate and blood pressure in patient with hypertension, increases cardiac output in patient with heart failure. Labetalol causes vasodilation, decreases heart rate and blood pressure. So AV means atrioventricular, ISA means intrinsic sympathomimetic activity, partial agonist activity, MSA means membrane stabilizing activity, local anesthetic activity. So this is again a summary of the drugs. Alpha adrenergic antagonist, phenoxybenzamine, lowers blood pressure, heart rate rises due to barof reflex activation. Phentolamine blocks alpha-mediated vasoconstriction, lowers BP, increases heart rate barof reflex. So prazosin, doxycycline, lower BP. Tamoxifenolin, alpha-1A blockage may relax prostatic smooth muscle more than muscular smooth muscle. Yohimbine raises BP and heart rate. Labetalol, lower BP with limited heart rate increase. Beta adrenoreceptor antagonist, propranolol, nadolol, timolol, all lower heart rate and blood pressure, reduce renin. Metoprolol, atenolol, pyrinol, beta-hexenol, nebivolol, lower heart rate and BP, reduce renin, may be safer in asthma. Butoxamine increases peripheral resistance. Pindolol, acebutolol, cardinolol, bopinetonolol, oxprinol, celiprolol, penbutenol, hypertension, arrhythmias, migraine may avoid worsening of bradycardia, but lowers BP moderately, lower the heart rate. Carvedilol, midoxilol, buccinidrol, used in heart failure. Esmolol, very brief cardiac beta blockage, rapid control of blood pressure, arrhythmia, thyrotoxicosis, and myocardial ischemia intraoperatively. Tyrosine hydroxylase inhibitor, tyrosine lowers BP in central nervous system, may elicit extrapyramidal effects due to low dopamine, and also the main clinical application is phenochromocystoma. Drugs affecting neurotransmitter release or uptake. Some agents act on adrenergic neuron either to interfere with neurotransmitter release from storage vesicles or to alter uptake of neurotransmitter into adrenergic neuron. However, due to advent of newer and more effective agents with fewer side effects, these agents are seldom used therapeutically. Reserpine is one of the remaining agents in this category. Reserpine, a plant alkaloid, blocks magnesium adenosine triphosphate dependent transport of biogenic amines, norepinephrine, dopamine, and serotonin from cytoplasm into storage vesicles in adrenergic nerve terminals in all body tissues. This causes ultimate depletion of biogenic amines. Sympathetic function in general is impaired because of decreased release of norepinephrine. Reserpine has slow onset, long duration of action, and effects that persist for many days after discontinuation. It has been used for management of hypertension, but has largely been replaced with newer agents with better side effects profiles and fewer drug interactions. It is also indicated in agitated psychotic states such as schizophrenia to relieve symptoms. Let's continue with questions with answers. Botulinum toxin blocks the release of acetylcholine from cholinergic nerve terminals, which is a possible effect of botulinum toxin. A. Skeletal muscle paralysis. Acetylcholine released by cholinergic neurons acts on nicotinic receptors in the skeletal muscle cells to cause contraction. Therefore, blockage of acetylcholine release causes skeletal muscle paralysis. Myasthenia gravis is an autoimmune disease where antidotes are produced against nicotinic receptors and inactivate nicotinic receptors. A reduction in acetylcholine release therefore worsens, not improves symptoms of this condition. Reduction in acetylcholine release by botulinum toxin causes reduction in secretion, including saliva, not increase in saliva, causing dry mouth and increase, not reduction in heart rate due to reduced vagal activity. Patient develops urinary retention after abdominal surgery. Urinary obstruction was ruled out in this patient. Which strategy would be helpful in promoting urination? The answer is inhibiting cholinesterase enzyme. Activation of muscarinic receptors in the detrusor muscle of the urinary bladder can promote urination in patients where the tone of detrusor muscle is low. Inhibiting cholinesterase enzyme increases the levels of acetylcholine, and acetylcholine can increase the tone of the detrusor muscle. There are no nicotinic receptors in the detrusor muscle. Therefore, activation of nicotinic receptors is not helpful. Inhibiting the release of acetylcholine or blocking muscarinic receptors worsen urinary retention. Which of the following drugs could therapeutically improve asthma symptoms? The answer is atropine. Muscarinic antagonists and drugs that increase acetylcholine levels cause constriction of bronchial smooth muscles and could exacerbate asthma symptoms. Bethanicol and pilocarpine are muscarinic agonists, and pyridoxyticmine is a cholinesterase inhibitor that increases levels of acetylcholine. Atropine is a muscarinic antagonist and therefore does not exacerbate asthma. Therefore, it should relieve symptoms of asthma, not used clinically for this purpose. If an ophthalmologist wants to dilate the pupils for an eye examination, which class of drug is therapeutically useful? The answer is muscarinic receptor inhibitor, that is antagonist. Muscarinic antagonist muscarinic agonist, for example, pilocarpine contract the circular smooth muscles in the iris sphincter and constrict the pupil meiosis. Anticholinesterase, for example, neostigmine, pyridostigmine also cause meiosis by increasing the level of acetylcholine. Muscarinic antagonists, on the other hand, relax the circular smooth muscles in the iris sphincter and cause dilation of the pupil, that is mydriasis. In Alzheimer's disease, there is a deficiency of cholinergic neuronal function in the brain. Theoretically, which strategy is useful in treating symptoms of Alzheimer's disease? The answer is C, inhibiting the acetylcholinesterase enzyme in brain. Because there is already a deficiency in brain cholinergic function in Alzheimer's disease, inhibiting cholinergic receptors or inhibiting the release of acetylcholine worsens the condition. Activating the acetylcholinesterase enzyme increases the degradation of acetylcholine, which also worsens the condition. However, inhibiting the acetylcholinesterase enzyme helps to increase the levels of acetylcholine in the brain and thereby relieve the symptoms of Alzheimer's disease. Elderly female who lives in farmhouse was brought to emergency room in serious condition after ingesting liquid from unlabeled bottle found near her bed, apparently in suicide attempt. She presented with diarrhea, frequent urination, convulsions, breathing difficulties, constricted pupils, myiasis, and excessive salivation. Which of the following is correct regarding this patient? She most likely consumed an organophosphate pesticide. The symptoms are consistent with that of cholinergic crisis. Since the elderly female lives on a farm and symptoms are consistent with a cholinergic crisis, usually caused by cholinesterase inhibitors, it may be assumed that she has consumed an organophosphate pesticide, irreversible cholinesterase inhibitor. Assuming that the symptoms are caused by organophosphate poisoning, administering an anticholinesterase agent or a cholinergic agonist will worsen the condition. The symptoms are not consistent with that of sympathetic activation, as sympathetic activation will cause symptoms opposite to that of cholinergic crisis seen in this patient. Patient who received non-depolarizing neuromuscular blocker for skeletal muscle relaxation during surgery is experiencing mild skeletal muscle paralysis after surgery. Which drug could reverse this effect of neuromuscular blockers? The answer is neostigmine. Neuromuscular blockers act by blocking nicotinic receptors on the skeletal muscles. Increasing the levels of acetylcholine in the neuromuscular junction can reverse the effects of neuromuscular blockers. Therefore, neostigmine, a cholinesterase inhibitor, could reverse the effects of neuromuscular blockers. Pilocarpine and methanicol are preferentially muscarinic agonists and have no effects on the nicotinic receptors. Atropine is a muscarinic antagonist and has no effect on nicotinic receptors. 60 years old female who had a cancerous growth in neck region underwent radiation therapy. Her salivary secretion was reduced due to radiation and she suffers from dry mouth xerostomia. Which drug would be most useful in treating xerostomia in this patient? The answer is pilocarpine. Salivary secretion may be enhanced by activating muscarinic receptor in the salivary glands. This can be achieved in theory by using a muscarinic agonist or an anticholinesterase agent. Pilocarpine is muscarinic agonist administered orally for this purpose. Acetylcholine has similar effects as that of pilocarpine. However, it cannot be used theoretically as it is rapidly destroyed by cholinesterase in the body. Ecothiopate is an irreversibly cholinesterase inhibitor, but it cannot be used therapeutically because of its toxic effects. Atropine is a muscarinic antagonist and worsens dry mouth. 40-year-old male presents to his family physician with drooping eyelids, difficulty chewing and swallowing, and muscle fatigue even on mild exertion. Which agent could be used to diagnose myasthenia gravis in this patient? The answer is adrophonium. The function of nicotinic receptors in skeletal muscle is diminished in myasthenia gravis due to the development of antibodies in two nicotinic receptors, autoimmune disease. Any drug that increases levels of acetylcholine in the neuromuscular junction can improve symptoms in myasthenia gravis. Thus, endorphorium, a reversible cholinesterase inhibitor with a short duration of action, can temporarily improve skeletal muscle weakness in myasthenia gravis, serving as a diagnostic tool. Atropine is a muscarinic antagonist and has no role in skeletal muscle function. Pralidoxime is a drug that is used to reverse the binding of irreversibly cholinesterase inhibitors with cholinesterase enzyme and helps to reactivate cholinesterase enzyme. Hence, paralidoxime will not be useful in improving skeletal muscle function in myasthenia gravis. Atropa belladonna is a plant that contains atropine, a muscarinic antagonist. Which of the following drugs or classes of drug will be most useful in treating patients with belladonna? The answer is physostigmine. Atropine is a competitive muscarinic receptor antagonist that causes anticholinergic effects. Muscarinic agonists or any other drugs that increase the levels of acetylcholine are able to counteract effects of atropine. Thus, anticholinesterases such as malathion and physostigmine can counteract the effect of atropine. In theory, however, since malathion is an irreversible inhibitor of acetylcholinesterase, it is not used for systemic treatment in patients. Muscarinic antagonists worsen the toxicity of atropine. Nicotinic antagonists can worsen the toxicity by acting on parasympathetic ganglionic receptors and thus reducing the release of acetylcholine. During an ophthalmic surgical procedure, surgeon wanted to constrict pupil using a narcotic drug. However, he accidentally used another drug that cause dilation of the pupil, mydriasis. Which drug was most likely used? The answer is topicamide. So, very interesting question. So, let's see what is the reason behind this choice. Norepinephrine muscarinic agonists such as acetylcholine, pilocarpine, and methacol contract the circular muscles of iris sphincter and cause constriction of the pupil myosis, whereas muscarinic antagonists such as topicoramide prevent contraction of the circular muscle of the iris and cause dilation of the pupil mydriasis. Serine is a nerve gas that is an organophosphate cholinesterase inhibitor. Which agent could be used as an antidote to serine poisoning? The answer is atropine. Serine is an organophosphate cholinesterase inhibitor. It causes an increase in acetylcholine levels in tissues that leads to cholinergic crisis through activation of muscarinic and nicotinic receptors. Most symptoms of cholinergic crisis are mediated by muscarinic receptors, and therefore the muscarinic antagonist atropine is used as an antidote for serine poisoning. Cholinergic agonists such as pilocarpine, carbachol, and physostigmine indirect and agonists worsen symptoms of serine poisoning. Patient with Alzheimer's disease needs treatment for overactive bladder. Which drug is the best choice for this patient? The answer is trospium. All of agents for overactive bladder except tropism cross the blood-brain barrier to various degrees and could worsen dementia symptom in Alzheimer's disease. Trospium is a quaternary ammonium compound that minimally crosses the blood-brain barrier. Patient with asthma was prescribed a beta-2 agonist for acute relief of bronchospasm but did not respond to treatment. Which drug is the most likely next option for this patient? The answer is ipratropium. Major receptors present in the bronchial tissues are muscarinic and adrenergic beta-2 receptors. Muscarinic activation causes bronchoconstriction and beta-2 receptor activation causes bronchodilation. Therefore, a direct or indirect physostigmine muscarinic antagonist versus bronchospasm. Ipratropium is a muscarinic antagonist that can relax bronchial smooth muscles and relieves bronchospasm in patients who are not responsive to beta-2 agonist. Benztropine is used in the treatment of Parkinson's disease or relief of extrapyramidal symptoms from antipsychotics. Oxybutynin is used for overactive bladder. 50-year-old male who is non-compliant with medications was recently diagnosed with chronic obstructive pulmonary disease. His physician would like to prescribe inhaled anticholinergic that is dosed once or twice daily. Which drug is most appropriate for his patient? The answer is tiotropium. The physician should prescribe a long-acting muscarinic antagonist so that the patient has to inhale the medication only 1 or 2 times daily. Tiotropium is a long-acting muscarinic antagonist, whereas ipratropium is a short-acting muscarinic antagonist. Atropine and trospium are muscarinic antagonists but are not indicated for pulmonary conditions such as asthma or chronic obstructive pulmonary disease and are not available as inhaled formulations. Which is the most effective drug for motion sickness for a person planning to go on a cruise? The answer is scopolamine. All muscarinic antagonist anticholinergic drugs listed are theoretically used as anti-motion sickness drugs. However, scopolamine is the most effective in preventing motion sickness. Tropicamide mostly has ophthalmic uses, and phasothirodine is used for overactive bladder. Which is correct regarding ganglion blocking drugs? Blockage of sympathetic ganglia could result in reduced blood pressure. Selective blockage in theory of the symptomatic ganglion causes reduction in norepinephrine release and therefore reduction in heart rate and blood pressure. Selective blockage in theory of the parasympathetic ganglion causes reduction in acetylcholine release and increase in heart rate. Receptors at both sympathetic and parasympathetic ganglia are of the nicotinic type. Nicotine is an agonist at nicotinic receptors and produces a depolarizing block in the ganglia. Atropine is a muscarinic antagonist and has no effect on the nicotinic receptors found in the ganglia. Which drug is useful in treating sinus bradycardia? The answer is atropine. Sinus bradycardia is a condition where the heart rate is slow, below normal, and most often caused by increased vagal tone, increased release of acetylcholine in the sinoatrial node that acts on muscarinic receptors to reduce heart rate. A muscarinic antagonist such as atropine is useful in this situation to bring this heart rate back to normal. Succinylcholine and caesatracuronium are nicotinic antagonists and have no effect on muscarinic receptors in the sinoatrial node. Neostigmine is a cholinesterase inhibitor and can worsen bradycardia by increasing the level of acetylcholine in the sinoatrial node. ICU patient with severe lung injury requires a neuromuscular blocking agent to assist in his ventilator management. He has liver disease and is currently in renal failure. Which neuromuscular blocker is the best choice for this patient? The answer is caesatracurium. Pancuranium is renally eliminated and the patient has renal failure. Vanicuranium and rocuranium are hepatically metabolized and the patient has liver disease. So, caesatracurium is cleared by organ-independent metabolism, Hoffman elimination. Where would you expect to see first return of function in skeletal muscle following decontinuation of a non-depolarizing neuromuscular blocking agent? The answer is B, diaphragm. Following administration of a neuromuscular blocker, the facial muscles are important first, but the pupils are not controlled by skeletal muscles and are not effective. The fingers and arms would be next, with the diaphragm function last. Function returns in the opposite order. So function of the diaphragm returns first. Which of the following is correct regarding adrenergic neurotransmission? Norepinephrine is the major neurotransmitter released from sympathetic nerve terminals. So the answer is, the reason of this answer is norepinephrine is the major neurotransmitter released from sympathetic nerve terminals. Norepinephrine is mainly released from the adrenal glands. Tricyclic antidepressants and cocaine inhibits the reuptake of norepinephrine into the sympathetic nerve terminals, but they do not prevent the release of norepinephrine. Dopamine is converted to norepinephrine by dopamine beta hydroxylase, not by monoamine oxidase. Which of the following adrenergic drugs is used in the treatment of overactive bladder? The answer is mirabegron. Retrosal muscles in the urinary bladder will wall have beta-3 receptors. Stimulation of these receptors relaxes the urinary bladder wall and relieves overactive bladder. Mirabegron is a beta-3 agonist and therefore used in treating overactive bladder. None of the above drugs listed have beta-3 agonist activity. Which of the following classes of adrenergic agents has utility in the management of hypertension? The answer is alpha-2 agonist. Alpha-2 agonists activate alpha-2 receptors located in the presynaptic terminal of sympathetic neurons and cause a reduction in the release of norepinephrine from sympathetic nerve terminals. This leads to a reduction in blood pressure. Alpha-2 agonists such as clonidine and methyl-dopa are therefore used as antihypertensive agents. Alpha-1 agonists cause vasoconstriction and beta-1 agonists cause increased cardiac output and renin release. So these agents may increase blood pressure. Beta-3 agonists are not used in the treatment of hypertension. Which of the following is correct regarding responses mediated by adrenergic receptors? Stimulation of alpha-1 receptors increases blood pressure. Stimulation of alpha-1 receptors mostly found in blood vessels causes vasoconstriction and an increase in blood pressure. Stimulation of alpha-2 receptors on the sympathetic presynaptic terminal reduces the release of norepinephrine. Beta-2 receptors are not found in the heart. So activation of beta-2 receptors does not affect heart rate. Stimulation of beta-2 receptors found in the bronchial tissues causes bronchodilation, not bronchoconstriction. Asthma patient was given a non-selective beta agonist to relieve bronchoconstriction. Which adverse effect would you expect in this patient? The answer is tachycardia. A non-selective beta agonist activates both beta-1 and beta-2 receptors. Beta-1 activation causes an increase in heart rate, tachycardia, contractility, and subsequent increase in blood pressure. It relieves bronchoconstriction because of the beta-2 receptor activation. 12-year-old 22-year-old is brought to emergency room with suspected cocaine overdose. Which of following symptoms is most likely in the patient? The answer is hypertension. Cocaine is an indirect adrenergic agonist that prevents the reuptake of norepinephrine into the nerve terminals, thus increasing the levels of norepinephrine in the synaptic cleft. The increase in norepinephrine level leads to an increase in the blood pressure, hypertension, tachycardia, not bradycardia, mydriasis, not meiosis, and other symptoms of sympathetic overactivity. 12-year-old boy with a peanut allergy is brought to the emergency room after accidental consumption of peanuts. He is in anaphylactic shock. Which of the following drug is most appropriate to treat this patient? The answer is epinephrine. Norepinephrine has more alpha agonist effect and activates mainly alpha 1, alpha 2, and beta 1 receptors. Epinephrine has more beta agonist effects and activates mainly alpha 1, alpha 2, beta 1, and beta 2 receptors. Phenylephrine has predominantly alpha effects and activates mainly alpha 1 receptors. Dobutamine mainly activates beta 1 receptors and has no significant effects on beta 2 receptors. Thus, epinephrine is the drug of choice in anaphylactic shock, and that can both stimulate the heart beta 1 activation and dilate bronchioles beta 2 activation. Elderly patient is brought to the emergency room with a blood pressure of 76 by 60 millimeter of mercury, tachycardia, and low cardiac output. He is diagnosed with acute heart failure. Which of the following drugs is most appropriate to improve his cardiac function? The answer is dobutamine. Among the choices, the ideal drug to increase contractility in acute heart failure is dobutamine. Since it is a selective beta 1 adrenergic agonist, phenodilpam is a dobutamine agonists used to treat severe hypertension. The other drugs are non-selective adrenergic agonists that could cause unwanted side effects. Which of the following adrenergic agonist is commonly present in nasal sprays available over the counter to treat nasal congestion? The answer is oxymetazoline. Drugs with selective alpha 1 agonist activity are commonly used as nasal decongestant because of their ability to cause vasoconstriction in the nasal vessels. Oxymetazoline is an alpha 1 agonist and therefore the preferred drug among the choices as a nasal decongestant. Clonidine is an alpha 2 agonist. Albuterol is beta 2 agonist, and formoterol is a long-acting beta 2 agonist. Patient who has hypertension and mild asthma attack brought herbal remedy for asthma online. He doesn't take any prescription medications for asthma, but takes beta 1 selective blocker for hypertension. The herbal remedy relieves the asthma attacks, but his blood pressure seems to increase despite beta blocker therapy. Which of the following drugs is most likely present in the herbal therapy? The answer is ephedrine. Both ephedrine and salmeterol can relieve asthma symptoms as they activate beta 2 receptors in the bronchioles and cause bronchodilation. However, salmeterol is a selective beta 2 agonist and should not increase the blood pressure. By contrast, ephedrine stimulates the release of norepinephrine and acts as a drug agonist and alpha and beta adrenergic receptor, thus causing an increase in blood pressure. Phenylephrine, a non-selective alpha agonist, does not cause bronchodilation, so it would not relieve asthma symptoms. Norepinephrine is a non-selective adrenergic agonist that does not have any stimulatory effects on beta 2 receptors. In addition, norepinephrine is not active when given orally. Next question is 60-year-old patient started a new antihypertensive medication. His blood pressure is well controlled, but he complains of fatigue, drowsiness, and fainting when he gets up from the bed. Orthostatic hypertension. Which of the following drugs is he most likely taking? Prazosin. Because they block alpha 1 mediated vasoconstriction, alpha blockers, prazosin, are more likely to cause orthostatic hypertension as compared to beta blockers, metoprolol, propranolol. Alfuzosin is a more sensitive, selective antagonist for alpha 1A receptors in the prostate and bladder and is less likely to cause hypertension than prazosin. 30-year-old male patient was brought to the emergency with amphetamine overdose. He presented with high blood pressure and arrhythmias. Which drug is the most appropriate to treat the cardiovascular symptoms of amphetamine overdose in this patient? The answer is labetalol. Amphetamine is an adrenergic agonist that mainly enhances the release of norepinephrine from peripheral sympathetic neurons. Therefore, it activates all types of adrenergic receptors, that is alpha and beta receptors, and causes an increase in blood pressure. Since both alpha and beta receptors are activated indirectly by amphetamine, alpha blockers, prazosin, or beta blockers, metoprolol, nebivolol alone cannot relieve the cardiovascular effects of amphetamine poisoning. Labetalol blocks both alpha-1 and beta receptors and can minimize the cardiovascular effects of amphetamine overdose. New antihypertensive drug was tested in an animal model of hypertension. The drug was given alone, reduces blood pressure in the animal. Norepinephrine, when given in the presence of this drug, did not cause any significant change in blood pressure or heart rate in the animal. The mechanism of action of the new drug is similar to which of the following agents? The answer is carvedilol. Norepinephrine activates both alpha-1 and beta-1 receptors and causes an increase in heart rate and blood pressure. A drug that prevents the increase in the blood pressure caused by norepinephrine should be similar to carvedilol that antagonizes both alpha-1 and beta-1 receptors. Doxazocin is an alpha-1 antagonist, clonidine is an alpha-2 agonist, and atenolol is a beta antagonist. And these drugs cannot completely prevent the cardiovascular effects of norepinephrine. Beta blocker was prescribed for hypertension in a patient with asthma. After a week of treatment, the asthma attacks got worse, and the patient was asked to stop taking the beta blocker. Which beta blocker would you suggest as an alternative that is less likely to worsen the asthma? The answer is metoprolol. The patient was most likely given a non-selective beta blocker antagonizes both beta-1 and beta-2 receptors that made its asthma worse due to beta-2 antagonism. An alternative is to prescribe a cardioselective antagonizes only beta-1 beta blocker that does not antagonizes beta-2 receptors in the bronchioles. Metoprolol is a cardioselective beta blocker. Propranolol, labetalol, carvedilol are non-selective beta blockers and could worsen the asthma. 70-year-old male is treated with doxazocin for overflow incontinence due to his enlarged prostate. He complains of dizzy spells while getting up from a bed at night. Which drug would you suggest as an alternative that may not cause dizziness? The answer is tamsulosin. Dizziness in this elderly patient could be due to obstetric hypertension caused by doxazocin. Tamsulosin is an alpha-1 antagonist that is more selective to the alpha-1 receptor subtype alpha-1A present in the prostate and less selective to the alpha-1 receptor subtype alpha-1B present in the blood vessels. Therefore, tamsulosin should not affect blood pressure significantly and may not cause dizziness. Trazodone and phenterlamine antagonize both these subtypes and cause significant hypertension as a side effect. Propranolol is a non-selective beta blocker that is not indicated in overflow incontinence. 50-year-old male was in anaphylactic shock after being stung by a hornet. The medical team tried to reverse the bronchoconstriction and hypertension using epinephrine. However, the patient did not fully respond to the treatment. The patient's wife mentioned that he is taking a prescription medication for blood pressure. Which medication is he most likely taking that contributed to a reduced response to epinephrine? The answer is propranolol. Epinephrine reverses hypertension by activating beta-1 receptors and release bronchoconstriction by activating beta-2 receptors in anaphylaxis. Since epinephrine was not effective in reversing hypertension or bronchoconstriction in this patient, it could be assumed that the patient was on a non-selective beta blocker, propranolol. Doxazocin, alpha blocker, metoprolol, or acebutolol, both alpha-1 selective blockers, would not have completely prevented the effects of epinephrine. Which of the following is correct regarding alpha adrenergic blockers? Alpha adrenergic blockers are used in the treatment of benign prostate hyperplasia. Alpha-1 adrenergic blockers are used in treatment of benign prostatic hyperplasia because of their relaxant effect on prostate smooth muscles. Being antihypertensive agents, they are not useful in treating hypertension in anaphylaxis. Alpha-adrenergic blockers generally cause reflex tachycardia, not bradycardia, due to the significant drop in blood pressure caused by them. They increase, not reduce, the frequency of urination by relaxing the internal sphincter of the urinary bladder, which is controlled by alpha-1 receptors. Which of the following is correct regarding beta blockers? Treatment with beta blockers should not be stopped abruptly. If beta blocker therapy is stopped abruptly, they could cause angina and rebound hypertension. This could be due to the upregulation of beta receptor in the body. Beta blockers do not cause direct relaxation, vessel relaxation, therefore they do not decrease peripheral resistance with short-term use. Propranolol is a non-selective beta blocker, not cardioselective. Cardioselective beta blocker antagonize only beta-1 receptors and do not worsen asthma as they do not antagonize beta-2 receptors. Which of the following drugs is commonly used topically in the treatment of glaucoma? The answer is timolol. Beta blocker reduce the formation of aqueous humor in the eye and therefore reduce intraocular pressure, thus relieving glaucoma. Timolol is a non-selective beta blocker that is commonly used topically to treat glaucoma. Esmolol is a short-acting beta blocker that is used intravenously for hypertension or arrhythmias. Silodosin is a alpha-1 antagonist used for benign prostate hyperplasia. Yohimbine is an alpha-2 antagonist used for sexual dysfunction. Which of the following drugs has the highest potential to worsen orthostatic hypertension when given together with prazosin? The answer is labetalol. Labetalol is a non-selective beta blocker with alpha-1 blocking activity. Prazosin causes orthostatic hypertension due to its alpha-1 blockage, which could be enhanced by adding labetalol, propranolol, atenolol, and nebivolol do not have alpha-1 blocking agents. Man complains of dry mouth after radiation therapy for throat cancer, and A is treated with cevimeline. Which mechanism produces therapeutic effect of this drug? The answer is increased formation of IP3. Increased formation of IP3, cevimeline is a muscarinic receptor agonist in salivary gland. Muscarinic M3 receptor activation leads to stimulation of phospholipase C and formation of IP3 and diacylglycerol. IP3 releases intracellular calcium, which increases salivation of saliva. Women in smoking cessation program receiving drug that reduces craving and withdrawal effects. Which effect results from receptor activation by this drug? The answer is sodium influx. The patient most likely receives varenicline, a partial agonist at nicotinic receptors in the brain. Nicotinic receptors are ligand-gated sodium channels, and their activation leads to sodium influx. None of the other option is an effect of varenicline. Man receives a drug that increases CGMP levels. Which adverse effect is most likely to result from this medication? Headache. Erectile dysfunction is treated with sildenafil and other drugs that inhibit breakdown of CGMP by 5-PDEs. These drugs cause vasodilation, which may lead to headache. A, B, C, and D, constipation, cough, dry mouth, sedation, are unlikely to be caused by a phosphodiesterase inhibitor. A culture worker is brought to the emergency department after abrupt onset of bowel and bladder incontinence and muscle weakness. He is given oxygen antidotal drug treatments. Which drug mechanism would increase muscle strength in this patient? The answer is increased neurotransmitter degradation. The patient has signs and symptoms of organophosphate phosphate toxicity that are caused by inhibition of cholinesterase and excessive stimulation of muscarinic and nicotinic receptors by acetylcholine. The treatment of organophosphate intoxication includes administration of paralidoxime, which reactivates cholinesterase and leads to increased acetylcholine degradation. The patient's muscle weakness is caused by prolonged depolarization of skeletal muscle, activation of nicotinic receptors. B would increase depolarization and muscle weakness. Which drug produces transient muscle fasciculations followed by muscle paralysis that is not reversed by neostigmine? The answer is succinylcholine. Succinylcholine is the only depolarizing neuromuscular blocking agent that produces persistent depolarization of the motor end plate, thereby causing transient muscle fasciculations followed by paralysis. Cholinesterase inhibitors acting to increase acetylcholine levels do not counteract the muscle paralysis produced by acetylcholine and can actually increase the degree of paralysis by prolonging muscle depolarization. Toxic doses of scopolamine would be expected to cause all of the following effects except bronchospasm. Muscarinic blockers such as atropine and scopolamine cause relaxation of bronchial smooth muscle and bronchodilation. These drugs may also cause hyperthermia by inhibiting sweating, thereby leading to vasodilation and flushing. Scopolamine causes blurred vision by relaxing the ciliary muscle, thereby producing cycloplegia, paralysis of accommodation. Topical ocular administration of tropicamide will cause relaxation of the iris sphincter muscle. Tropicamide binds to muscarinic receptors and competitively blocks acetylcholine released by the parasympathetic oculomotor nerve. This action leads to relaxation of iris sphincter muscle and dilatation of the pupil, mydriasis, thereby facilitating ophthalmic examination of the peripheral retina. The therapeutic use of derifenacin is based on its ability to relax urinary bladder smooth muscle. Derifenacin is used to treat hyperactive bladder and relieve urgency, frequency, and incontinence. It is not used to relax uterine, gastrointestinal, or bronchial smooth muscle. It can inhibit cellular secretion, causing dry mouth. Man with diabetic autonomic retinopathy complains of dizziness, fainting when arising from bed in the morning. Which drug would be the most beneficial to this patient? The answer is midodrine. Midodrine is a selective alpha-1 adrenoceptor agonist that is used to treat postural orthostatic hypertension. None of the other option increases systematic vascular resistance or counteracts postural hypertension. Women requires drug to lower intraocular pressure after contact surgery. Which mechanism would most likely lead to desired effect? The answer is inhibition of adenyl cyclase. Alpha-2 adrenoceptor agonists such as apraclonidine are used for short-term control of intraocular pressure after contact surgery. Activation of alpha-2 adrenoceptors is coupled with inhibition of adenyl cyclase and decreased KAM levels. Child with asthma is being treated with adrenoceptors agonists to prevent bronchospasm. Which side effect is typically associated with this drug? The answer is rapid heart rate. Beta-2 adrenoceptor agonists such as albuterol are used to relax bronchial smooth muscle and prevent bronchospasm in persons with asthma. These drugs also activate beta adrenoreceptors in the heart and increase heart rate, but do not typically cause low blood pressure, blood vision, sedation, or muscle weakness. After being stung by a bee, a woman experiences urticaria, laryngeal edema, difficult breathing, and hypotension. She received oxygen and administration of an adrenoceptor agonist. Which action would lead to bronchodilation? The answer is increased CAMP levels. The preferred treatment for severe hypersensitivity reaction, anaphylaxis, is epinephrine. The drug causes bronchodilation by activation of beta-2 adrenoreceptors in bronchial smooth muscle, leading to increased CAMP levels and smooth muscle relaxation. Although CAMP B option also mediates smooth muscle relaxation, levels of this substance are not significantly increased by beta-2 adrenoceptor activation. Increased IP3 levels, the option 3C, causes smooth muscle contraction as with calcium influx. D. Sequestration of calcium causes muscle relaxation, but this action is not invoked by beta-2 receptor stimulation. Next question. For each patient, select the most appropriate drug therapy from the latter choices. So, very interesting question. Let's see. Woman experiences pain and ischemia in her finger after accidentally injecting it with an auto-injector that she carries for emergency treatment for allergic reactions. So the answer is phentolamine. Ephedrine and other adrenoceptor agonists can cause excessive vasoconstriction and ischemia when injected into fingers, toes, or other tissues as a result of activating alpha-1 adrenoceptors in vascular smooth muscle. Phentolamine is a non-selective alpha adrenoceptor antagonist that can be injected directly into affected tissue to counteract the vasoconstructive effects of adrenoceptor agonists. Man complains of urinary urgency, frequency, and nocturia and is found to have benign enlargement of prostate gland. The answer is L-fusosine. Is a selective alpha-1 adrenoceptor blocker that acts to relax smooth muscle in the bladder outflow tract and thereby relieve urinary obstruction caused by prostatic hyperplasia. Alpha-fusosine is sometimes used in combination with finasteride, a drug that inhibits the conversion of testosterone to dihydrotestosterone and thereby reduces prostatic growth. Women with essential hypertension requires a drug that reduces both cardiac output and peripheral resistance. The answer is carvedilol. Carvedilol is a non-selective beta adrenoceptor antagonist and is a non-selective alpha-1 receptor antagonist that is used to treat hypertension. It acts to reduce cardiac output by blocking cardiac beta-1 adrenoreceptors and to reduce peripheral resistance by blocking alpha-1 receptors and vascular smooth muscle. Man with episodic severe hypertension is found to have markedly elevated levels of epinephrine and norepinephrine metabolites in his urine and required a long-acting drug to lower blood pressure before surgery. The answer is phenoxybenzamine. The patient most likely has a tumor of the adrenal medulla called pheocyrocytoma. This tumor secretes massive quantities of epinephrine, norepinephrine, thereby causing severe hypertension. Phenoxybenzamine is a non-selective, non-competitive, long-acting alpha adrenoreceptor antagonist that is sometimes used to reduce blood pressure in patients with this condition. Which drug is most likely to slow recovery from hypoglycemia in a diabetic patient who has taken an excessive dose of insulin? The answer is propranolol. Non-selective beta blockers such as propranolol are most likely to inhibit beta-2 receptor-mediated glycogenolysis and slow recovery from hypoglycemia. Selective beta-1 blockers such as atenolol and metoprolol are less likely to inhibit glycogenolysis than non-selective blockers and alpha adrenoreceptors blockers such as doxazosin and phentolamine are least likely to impair glycogenolysis. Women with facial muscle spasm is treated with an agent that inhibits the release of acetylcholine. Which side effect is most likely to occur in this patient? The answer is dry mouth. Man is arrested while using a substance that inhibits the catecholamine transporter in the neural memory. Which sign would most likely be observed in this person? The answer is dilation of the pupil. Women with acute high blood pressure is given a drug that inhibits formation of dihydroxyphenylalanine. Which response would result from this treatment? The answer is the decreased heart rate.